Welcome to meeting number 93 of the House of Commons Standing Committee on Health. Today's meeting is taking place in a hybrid format pursuant to the standing orders. I understand that we have one witness and one member participating virtually, so in accordance with our routine motion, I'm informing the committee that all remote participants have completed the required connection tests in advance of the meeting. For the one witness that we have by video conference, you're probably already aware of this, but you have translation available on the bottom of your screen, floor, English or French. Close the mic when you're not speaking, and avoid taking screenshots of the screen, please. Today from 11 to 1, we have a panel on the opioid epidemic and the toxic drug crisis. So pursuant to Standing Order 108 sub 2 and the motion adopted on November 8th, we're going to begin that study today. Before we begin, I'd like to introduce the officials that we have with us. From the Canadian Institutes of Health Research, Dr. Samuel Weiss, Scientific Director, Institute of Neurosciences, Mental Health and Addiction. That's the gentleman we have by video conference, and the others are in person from the Department of Health. Jennifer Sachs, Associate Assistant Deputy Minister, Controlled Substances and Cannabis Branch. Carol Ann Chénard, Directrice Générale par intérim, Bureau des Substances Contrôlées. Kelly Robinson, Director General, Marketed Health Products Directorate. From the Department of Indigenous Services, Jennifer Novak, Director General, Mental Wellness, First Nations and Inuit Health Branch. From the Department of Public Safety and Emergency Preparedness, Marie-Hélène Levesque, Directrice Générale, Direction de l'Application.
Director General, Law Enforcement and Policy Directorate.
The Agency of Canada, Shannon Hurley, Associate Director General, Centre for Mental Health and Wellbeing. Thank you all for taking the time to appear today. Before I hand the floor over to Ms. Sachs, I understand that there is a possibility of bells before we complete this panel. So if and when that happens, I'll be asking for unanimous consent to continue. And we have heard from the Minister of Mental Health and Addictions, who has indicated her willingness to come before the committee on this study probably in the new year. And with that, I'm going to turn the floor over to Jennifer Sachs from the Department of Health for her 5-minute opening statement. Ms. Sachs.
Thank you very much. Bonjour, bon matin.
Good day, good morning. Thank you for providing my colleagues and I with the opportunity to address this crucial issue. In my comments today, I would like to share some information about what we know about the crisis based on the data we collect at the federal level, and I'd like to outline some of the measures we've been advancing to reduce harms, prevent overdose and related deaths, and to expand access to treatment and support recovery and well-being. The overdose crisis we face today is a profound public health emergency reaching into the lives of individuals across diverse demographics. This public health crisis is having a tragic impact on people who use substances, their families, and communities across the country, and it's shaped by a wide variety of factors.
There have been 38,514 opioid overdose deaths since January 2016. While 90% of these deaths in Canada occurred in British Columbia, Alberta, and Ontario, it is important to note that elevated rates have also been observed in other areas with smaller population sizes, including Saskatchewan and Yukon. Most apparent opioid toxicity deaths are among young to middle-aged males. In fact, males accounted for the majority, that is 73%, of accidental apparent opioid toxicity deaths. Indigenous peoples are disproportionately impacted. For example, while First Nations make up 3% of British Columbia's total population, 16% of those who died of an overdose identified as First Nation. Also, according to data from the Alberta First Nations Information Governance Centre, the rate of opioid poisoning deaths is 7 times higher for First Nations people compared to non-First Nations people in the province. The data also confirm that very high rates of overdose deaths are the direct result of increasing street drug toxicity. Of all reported overdose deaths, 81% involve fentanyl. Multi-drug toxicity is a contributing factor to the crisis. Increasingly, people are using a mix of drugs, which is significantly increasing risk. Cette crise est généralisée.
This crisis is widespread and pervasive. Understanding why people turn to substances engages the full range of social determinants of health, as well as adverse childhood experiences, trauma, poverty, mental illness, and chronic pain.
To ensure we are pursuing evidence-based strategies to comprehensively and compassionately address this crisis. It is within this context that the Government of Canada has been actively working for many years, mobilizing efforts across a continuum of interventions that span prevention, harm reduction, treatment, and enforcement, and work together to reduce harmful stigmatizing attitudes and behaviors. Substance use prevention initiatives are tailored to reach people most at risk. For example, the Ease the Burden campaign is a targeted effort to reach men in the trades, a demographic disproportionately affected by the overdose crisis. This campaign, with over 26 million views, shows how we are raising awareness and reducing stigma in these populations. Recognizing how important timely access to quality treatment services is, we have made significant investments to expand access, including specialized services for youth and much-needed withdrawal management, commonly referred to as detox. The government has also made efforts to expand access to services which reduce harms and prevent overdose deaths. This includes the distribution of naloxone and widespread training. We have made it easier for communities to establish supervised consumption sites. There are currently 39 sites across the country which have seen over 4.3 million visits, responded to nearly 50,000 overdoses. For many, these sites are the only direct experience people will have with health providers. As a result, there have been over 257,000 referrals to health and social services. Simultaneously, our law enforcement and border officials are actively countering illegal drug production, diversion, trafficking, and related crimes. As part of the response to this crisis, the government also continues to support research that is helping us to better understand substance use in Canada and to allow for the development of evidence-based policies and programs. Avant de terminer, je voulais mentionner que le 30 octobre.
Before I close, I want to mention that on October 30th, 2023, the Minister of Mental Health and Addictions and Associate Minister of Health launched a renewed Canadian Drugs and Substances Strategy. This strategy presents a compassionate, equitable, collaborative, and comprehensive federal approach to this crisis and may be of interest for you to study. In conclusion, it is essential to understand that federal actions alone will not end the overdose crisis. We stand committed to ongoing collaboration with provinces and territories, Indigenous communities, families, and people with lived or living experience. We welcome the opportunity to inform your important study and are prepared to respond to any questions you may have. Thank you.
Thank you, Ms. Sachs. We're going to begin right away with rounds of questions, beginning with the Conservatives. Dr. Ellis, for 6 minutes, please.
Good morning, everyone, and thanks for getting to this very, very important study. Obviously, we know the statistics. Canadians know the number of people dying. 1,900 people have died, of course, thus far in 2023. Ms. Sachs, maybe you could tell listeners out there, what is the leading cause of death in BC in 10 to 18-year-olds?
10 to 59-year-olds in BC overdose deaths from opioids is the leading cause of death.
What about 10 to 18-year-olds specifically?
I believe that the leading cause of death for the 10 to 18-year age group is also overdose deaths.
Yeah, it's a very sad state of affairs. You know, I guess I have a bit of a rhetorical question, but we'll get to that. You know, what's it going to take to stop this experiment, the safer supply, whatever euphemism we're going to use? You know, there's a recent article came out, I think, on Friday, of a person with lived experience talked about being at the Leslieville, the South Riverdale site, speaking about safe supply. Are you aware of that article?
I'm not aware of the specific article. I would need more details, but I know that there have been a number of articles about safer supply, safer supply as well as supervised consumption sites in recent days.
This article specifically talks about safer supply, talks about a few other things, but is the Government of Canada aware that the so-called safer supply is ending up in the hands of folks who previously have not used opioids?
What the government is doing right now is undertaking and investing in a suite of services, which includes prevention, education, harm reduction, treatment.
I'm sorry, maybe you
recovery.
misheard me. I'll interrupt you. I apologize for that. But are you aware that the so-called safer supply is ending up in the hands of folks who've never used opioids before? I didn't ask what the government was doing. I asked a very, very specific question. Thank you.
So I think the government is aware that there are a range of views regarding prescribed pharmaceutical alternatives that are being used in harm reduction and treatment purposes for individuals who use substances. We are listening to those. I think we are listening to concerns as well, taking those very seriously. There are a number of actions that we are taking with
Okay,
respect to
thank you for that. I'll interrupt you there. We have a convention here that you'll answer in length of my question, so thank you. Is the government aware that the price on the street of a 8-milligram tablet of hydromorphone has gone from approximately $20 a pill to $2 a pill?
Again, I would repeat that we understand that there are a range of views and perspectives and reports in terms of prescribed pharmaceutical alternatives. We are taking concerns that are being raised seriously. We are looking into those. We are taking a number of actions.
Thank you very much. I'm trying to be very kind here, but I'm asking very specific questions to which you're really not answering. Is the government aware, your department aware, that the on-the-street price for 8-milligram tablets of hydromorphone has gone from $20 to about $2 a tablet?
We are aware that there are reported concerns with diversion of prescribed pharmaceutical alternatives, including as a result of the price of that.
Is the
related
government
to
aware
price.
that these tablets of hydromorphone, 8 milligrams, which is equivalent of about 30 tablets of Tylenol 3, is actually being used in high schools around this country?
I think the government is aware that the use of illegal drugs is absolutely of concern for youth across the country, and that is why we're investing in prevention and education in a suite of services and supports.
Once again, I'm going to interrupt you. I'm trying to be kind, but you really, it seems to be being purposefully avoiding answers to my questions. Is the government aware that the so-called safe supply is actually being used in high schools in Canada?
We are aware that there are people who are concerned that there is diversion of prescribed safer supply.
So I guess if you're aware that there people are being concerned if you are aware that people are concerned this is happening, then wouldn't that mean that you're aware that it's happening?
We are taking reports of diversion seriously. There are a number of actions that we are taking. We are committed to taking those actions. That includes working with safer supply products to understand the risk mitigation measures they are taking, including patient screening, including urine drug checking, screening, including working with healthcare providers and patients to ensure that risk mitigation measures are in place to reduce any diversion. We are looking at evaluations and studies, and I'm happy to turn it over to my colleague at CIHR for further information in terms of some of the evaluation that we are doing on
Thank you.
prescribed
Thank you for that.
alternatives.
When the opioid experiment began, and I'm using the words of my colleague, Dr. Hanley, which was in the text of this motion, what was the original null hypothesis that the government put forward for the experiment?
Could you repeat the question at the beginning?
Yes. What was the original null hypothesis generated for this experiment? We all know it was an experiment. It's never been done before. So in an experiment, you really have an idea of what you want to disprove. So what was it? Or was this just something on the back of a napkin, I guess is the question.
I apologize. I think you'll have to just clarify for me what you're referring to by this experiment.
Well, it's in the text of the motion that we're debating here today, that this is a drug experiment. So what was the plan?
I think the government...
So, sorry, was there a plan?
There is a plan. There's a very clear plan that the minister announced on October 30th, which really directs where the government is going, which is the renewed Canadian Drugs and Substances
Sorry,
strategy.
I'm just going to interrupt you because you said October 30th. I mean,
That's your time, Doctor, I'm sorry. Dr. Hanley, please, for 6 minutes.
Thank you, Mr. Chair. And before I ask questions, I wanted to provide some opening remarks, given that this is a study to which I initiated with the motion passed by committee earlier this year. Mr. Chair, we have 8 meetings, I believe, most of which will be taking place after the new year in 2024. And we know that 2023 will be another tragic year for Canadians. In 2022, we saw 7,328 deaths. The current death rate is estimated to be 21 Canadians dying daily. It's kind of shocking, isn't it, that we can actually predict with more or less confidence that 600 or more Canadians will die of an opioid or a mixed drug overdose between now and the end of the year. And despite this having been recognized as an emergency 7 years ago, the death toll continues to be the same or to rise. And when I was CMOH in the Yukon, we witnessed the first fentanyl death occurring in April in that province. And that's continued to increase since. And since those earlier days of the epidemic, governments have responded. Many wonderful things have happened. Naloxone kits, for instance, are everywhere in our territory and widespread around the country. We have had the first supervised consumption site in Yukon north of 60, including one of the first sites in the country with an inhalation room. We've scaled up efforts in treatment, in clinical opioid substitution, in harm reduction, and to some degree in prevention. The Yukon declared a substance use emergency in January 2022 and recently revised its substance use emergency health strategy just a few months ago, based on and growing on the 4-pillar approach that we all know so well. And yet the deaths go on, lives and families torn apart with overdose, fatalities, or injuries. We've done so much, yet the scale of our response has not yet matched the need. So as we take on the study, I plead all committee members around the table to have one aim, one single aim in mind. I know I'll be thinking of my own 2 teenagers and their friends and what more we can do to protect them. So let this be about saving Canadians' lives. Let's not have this about personal attacks or takedowns or scoring political points. And let's take a hard look at what is working, at what is not working, and if something is not working, let us examine why, learn, and adapt. So to my colleague, Dr. Ellis, an experiment is taking really a word for taking a new approach. To your question about a null hypothesis, I think we could answer that the current model that we have is clearly not working, and so we need to take new directions. So let us look at models of innovation and success that have shown promise or have shown to work, either within our country or elsewhere. Let us be able to come up at the end of this study with urgent, thoughtful, evidence-based, compassionate, bold and intelligent recommendations as to what all of us can do to get this epidemic under control as individuals, as communities, as governments at all levels. Now, I know that each one of us cares. So please, for the sake of Canadians, let's work together on this with respect, with humility, with urgency, and with the decency that Canadians expect of us. So I know I have only about 2 minutes left. But I'd like to just bring back my questions. Ms. Sachs, and thank you all of you for being here. Budget 2023 proposes to add an additional $359 million over 5 years to support a renewed strategy. And Ms. Sachs, I wonder if you could describe some of the directions you intend to take with this renewed funding. And I'd like to save time for maybe Ms. Hurley from the Public Health Agency to comment as well on that same question.
Perfect. Excellent. I absolutely will make sure to save time for Shannon Hurley as well. Thank you for that question and for your remarks. The renewed strategy really builds on the previous strategy, as you mentioned, with ensuring that we have holistic, integrated action that cuts across prevention and education, that looks at substance use services, the whole suite of substance use services, harm reduction, treatment, recovery, looks at making sure we're building on the evidence and taking a range of actions in terms of substance controls, looking at law enforcement and ensuring that the appropriate controls are there for misuse of substances. Some of the key actions that we're taking include call for proposals for substance use and addictions program to make sure that we can invest in community-based programs. Call for proposals went out at the end of September. Those, we've just received over 600 applications at the end of November. We'll be reviewing those to make sure that we can invest in promising evidence-building, innovative projects at the community level. Turn it over to Ms. Shannon Hurley in a minute to talk about some of the prevention work and building on the Icelandic prevention model-based programming that we have. We're continuing to take action in terms of authorization and making sure that people can have access to harm reduction services, whether that's supervised consumption sites, whether that's access to naloxone, whether that's making sure that drug checking services are available so that people can know what are in their drugs and that health workers as well know what are in the substances that people are consuming. There are a range of actions, and I can turn it over to my colleague after as well in terms of the public safety and law enforcement that we are taking, and their suite of surveillance activities and targeted research and evidence that we are looking to build up, including on innovative models so that we can learn and adjust as we are doing that. So for prescribed pharmaceutical alternatives, for supervised consumption sites, we are looking at what that evidence is showing, monitoring those programs so that we can learn and adapt and put in best practices. But maybe I'll turn it over to Shannon on
Thank
the
you,
prevention.
Ms. Sachs. We're past Dr. Hanley's time. I'm sure that if another member wants to use part of their time to have some further comments with respect to that, then that may very well happen. Suite, Monsieur Thériault, pour 6 minutes, s'il vous plaît.
Mr. Thériault, you have 6 minutes, sir. Thank you, Chair. Welcome. Welcome to the Standing Committee on Health. This very committee in 2016 tabled in the House a report with 38 recommendations. Among them was a recommendation to base our strategy on harm reduction, stating that the government should define harm reduction 7 years down the road. Are you able to briefly define harm reduction and the aim of policies based on it? Thank you very much for your question. Harm reduction remains a key pillar of the Government of Canada's current strategy to deal with overdose. It is one of many approaches we are taking, of course, but harm reduction is part of a care continuum. It is evidence-based. What does it do? It reduces harm and it saves lives. It's absolutely essential to continue to reduce harm, given the growing and unpredictable toxicity of the drug supply, of the street drug supply. Why are we continuing to use this approach, harm reduction? Because not everyone has access to treatment services. Some services aren't offered in some regions, and private care can be inaccessible or too costly. So harm reduction is used to establish a connection with users to be able to begin offering health services. Thank you. In the government's response to the committee's report, there was a matter of better supervision at the borders, tougher laws. For example, C-37, Bill C-37, would be allowing border agents to work more rigorously at intercepting fentanyl coming across the border because there would be better inspection of baggages for less than 30 grams. Right now, we see that the illicit trade in fentanyl and other drugs is basically ongoing, that the new legislation hasn't changed anything. So what can we do to ensure stricter control at the borders? And then also for you, Ms. Sachs, what are we missing? What can we do to make our plan more effective? Because it seems that we're not reaching the targets we'd set for ourselves. Ms. Lévesque, could you begin? Hello, and thank you for your question. Thank you, Chair. It's a pleasure to be here with you today. Speaking for public safety, we are a department covering a number of topics, and for the border services, a number of interventions have already gotten underway at CBSA, the last being a targeting center, a center that's really targeting opioids. And we're expecting rapid results from that intervention. It's just gotten up and running. We want to also be able to collect relevant data. We want to then act on the intelligence we'll gather, working with the international community and law enforcement. 7 years down the road, you say that you've adjusted the approach and the strategy, but only recently? Well, of course, this isn't the only intervention that we have started making use of. We continue to intercept large quantities of illegal drugs coming over the border, and we're operating within the nation, within Canada, also internationally, to gather information, intelligence. All right, so I take it then that this isn't alone will not help us solve this crisis. Whatever the efficacy of the approaches, 7 years later, we're still unable to stem the flow, whatever we do. That's what I'm understanding. And so we need to take action at a new level. Ms. Sachs, what's missing? What's the level we need to intervene at? What's wrong with the strategy 7 years down the road of applying it? What will make us more efficient to really tackle this crisis? It's important that in the renewed strategy, the Canadian Drugs and Substance Strategy, we are going ahead with interventions. As Ms. Lévesque said, there are new approaches we're taking, and we have a number of ongoing approaches as well. Yes, but what about the progress? How far have we gotten? Have you got any data on that? I think we have made progress, of course. We know that the supervised consumption sites have saved a great number of lives. We know how many people we've been able to connect to other health and social services. Also for public safety, yes. There have been intersectoral advances, and we have been able to seize drugs at the borders. All right, so we've saved lives. Without this strategy, without these measures taken, without this action plan, things would be even worse. Even more people would be dead. Is that what you're telling us? Yes. There would be more deaths. Also, as I said in my opening statement, what the federal government is doing is working with other levels of government, with experts, with people working in the communities. Everyone has a role to play. We all need to work together and work harder all together. Thank you, Ms. Sachs, and thank you, Mr. Thériault.
6 minutes.
For being here and for the work that you're doing. And I want to reiterate what Dr. Hanley said is, what's working, what's not working. Clearly, what we're doing isn't working. And I like the idea of talking about models of innovation and success, but also using sound data so that we have evidence-based decision-making and policies that are going to respond to this crisis. Now, one thing that we heard from doctors at the beginning in 2016, really when BC declared a public health emergency, they were calling for the federal government to declare also a national public health emergency. Can you explain why that hasn't happened? And the reason being is that you've heard me many times, I've met with all of you here on this panel, about the need for a plan and a timeline, and that is not in the renewed Canadian Drugs and Substances Strategy. It was something I outlined in Bill C-216, which was defeated by conservatives and most liberals. But that would have provided a timeline. That bill directed government to provide a timeline and a plan. So why is there no public health emergency or national public health emergency been declared?
I think the Government of Canada has recognized that the overdose crisis is a public health crisis. We've used a broad range of powers.
You even said it was a public health emergency, so why haven't we declared it?
I think we've regularly put out that it is a public health crisis and that there are a number of actions, including investments of over $1 billion that have been made in a suite of actions, including evidence-based actions, innovative actions. That's why we have the renewed strategy to help guide us forward, working in partnership with others. And as you mentioned, with the renewed strategy, really looking at investment in a suite of services and supports, and there are specific actions that we have. There's resources that have been associated and announced in budget 2023, and then for timelines associated, there's specific actions that have been taken, like the call for proposals for this.
I love all the buzzwords around, a compassionate approach, integrated, coordinated approach, but that requires a timeline and resources. I'm sorry, but $1 billion isn't even 1% of what we spent in response to the COVID-19 health emergency. So that's why we need to declare a national public health emergency so that we can force everyone to the table and actually develop a plan with provinces, with municipalities, with Indigenous nations so that it's coordinated and a cohesive strategy. And when I look at the Expert Task Force on Substance Use, the Canadian Association of Police Chiefs revealed they obviously put out their policy platform a few years ago, what they were commanding. The Chief Coroner at BC First Nations Health Authority, now the Death Review Panel in BC. It's unbelievable. We have a Death Review Panel on this issue. But they all have something in common. They've all cited that we need treatment on demand, recovery, prevention, education, and a safer supply of substances. They've been all unequivocally clear. Has any of them changed their position when it comes to safer supply, since that's been brought up earlier in this conversation that you're aware of?
I am not aware of changed positions. We are aware that there are a range of differing perspectives and reports in terms of prescribed pharmaceutical alternatives. But as you mentioned, it really is one action of multiple, no single action.
And the reason I'm just bringing that up because it was raised earlier. And, when I talk about safer supply to replace the toxic, unregulated drug supply that's killing people in our country, have you brought together the data of the pilots? Like I know that Dr. Sereda in London, Ontario, she's producing data, and the data is significant. Lower visits to hospitals, less hospitalization, less involvement in survival sex work and drug-related criminal activity for drug-seeking related crime. I mean, this is unbelievable, the stats that are coming out. Have you compiled these and released the data of all the SUAP funding so that people have a better understanding of how successful these pilots are working?
So there is absolutely quite a bit of data. I mean, we are collecting data. We are evaluating programs, and so there is a number in terms of prescribed safer supply. There are prescribed pharmaceutical alternatives. My apologies. There are a number of studies underway. There's over 30 published evaluation results. Some of them are quite promising. The London study, as you mentioned, is one of them. The Ontario Drug Policy Research Network identified 20 publications and looked at promising outcomes, including reduced visits to emergency departments, hospitalization, reduced overdoses, reduced illegal drugs. There's a number of evaluations that have been undertaken by CIHR and the Canadian Research Initiative for Substance Misuse, CRISM, looking at the effectiveness of supervised consumption sites, of a number of different, Section 56 exemptions.
The Expert Task Force on Substance Use, I think they could provide a pivotal role of being an external body with experts that could help, go through that data and help make sure that the Canadian public has a third party, in terms of evaluation of how that data is working, how the policies of your government, the government currently is, and how you're doing with your renewed strategy on substance use policy. Has that been considered? Is that something that the minister's considering right now?
So the expert task force provided 21 recommendations that informed the renewed drugs renewed Canadian drugs and substances strategy.
I'm looking
and
for
to try-
oversight, though. Like, that's a necessary role, I think, in a
And
situation
we continue
like this.
to engage with quite a number of experts. We have, there's been expert advisory group on safer supply. There's people with lived and living experience councils. There are various different expert groups. We continue to engage with a number of those
They
experts,
don't have
including
accountability.
evaluation and
There's
data.
no
Thank
accountability.
you, Mr. Johns. Thank you, Ms. Sachs. Next, Mr. Doherty, please, for 5 minutes.
Thank you, Mr. Chair. There's a few things I could start off with. I could answer Dr. Hanley's or reply to Dr. Hanley's comment. This is deeply personal for me. I'm not here for sound bites, but I'm angry and I am frustrated. I've been very vocal and upfront about my family's struggles with this horrible epidemic. I've sat with family members of children, both that are now addicted and in the grips of addiction, but families that have also lost loved ones, young children, teens, to this horrible epidemic. So this is deeply personal. To our guests, thank you for being here. Thank you for the work you're doing. But I have to say, whatever it is that we're doing, it's not working. Ms. Sachs, you even said so yourself. Since 2016 to now, 38,000. Whatever it is that we're doing, it's not enough. I get that you're one team and our provinces and others have to do pitch in as well. It's not working. My colleague talked about the experiment. An experiment is to see what works, what doesn't work, throwing $1 billion at it, and the leading cause of death for 10 to 18-year-olds in my province is overdose. It's not working. What are the rates of diversion from government-funded safe supply? Anyone?
Yeah. So as I mentioned earlier, we are working with all
You
of our...
don't have those. You don't have those numbers.
Mr. Doherty, you took a minute and a half to ask the question, and then you interrupted her before she got into her second
Technically,
sentence.
sir, when I asked the question, it was short.
So, Ms. Sachs, if you have a more comprehensive answer, you go ahead.
What I would note is that prescribed pharmaceutical alternatives builds on medication-assisted treatment. And when we look, and when you speak about diversion, first of all, drug trafficking is illegal. We've been very clear about that. Whether that is for, whether that's diversion of pharmaceuticals that have been prescribed for chronic pain, for medication-assisted treatment, or for prescribed,
Do you have a percentage amount of government-funded safe supply that's being diverted?
we are working with our
Okay.
projects to be able to, they all have risk mitigation programs in place. We are
Right.
looking at seeing
So I'm
what are
just
the
looking
best
for a number.
practices.
I'm just looking for a percentage. If we don't have it, that's easy to deal with. What is the average wait time for recovery, to get somebody into recovery in Canada?
There's not good data across Canada, all provinces and territories, and consistent indicators in that regard.
So, how about, do you have a range? Is it a
can
week,
let you know
2
that-
weeks? Because I can tell you that in my province, it's sometimes up to 18 months or longer.
It's an excellent question, because it's exactly why Kai-Hi, in working with the health transfers that are going in the 200 billions, which include 25 billion in new investments, which includes for mental health and substance use services, that Kai-Hi is working with provinces and territories and with partners to be able to get, work closely with them, work with data partners to refine indicators and better collect consistent data.
Are you familiar with the letter from the 17 leading addictions doctors or physicians? Have you met with that group?
I have not met with that.
Okay. Are you familiar with the letter from November 6th from 42 leading group clinicians with addictions medicine? Have you met with that group?
We have met with a range of experts. We continue to meet with a range of experts, and we are continuing to collect data and evidence to better understand the concerns
Okay.
and make sure that our actions are grounded in evidence. And I think this
get
is what
that,
we have been saying.
Ms. Sachs, but I'm specifically asking about the authors of these two letters. Have you met with either of these groups?
We've not met with them as
Okay.
a group.
Okay. So both these groups, They say that safe supply is a nice marketing slogan, but it's not working. It's creating a whole new group that are addicted to opioids. Would you agree with that?
How to choose the right audio apps
Oh,
for you.
I'm sorry. Siri's listening. Hopefully others are as well. Would you agree with that, that it is creating, safe supply is creating, with what we know, safe supply is creating a whole new group of those that are addicted to opioids?
Prescribed pharmaceutical
All I'm asking
alternatives
is, would you agree with that?
is
With that statement?
Okay,
is
Ms.
one
Sachs,
of a range of
there'll be no more
actions.
questions. Take the time you need to answer the question.
Prescribed pharmaceutical alternatives is one amongst many actions. I think it's been clear that we need a range of actions. No single action can be taken and will resolve the overdose crisis in and of itself.
Didn't
It's
answer my
important to have a
question.
suite, and I will note that prescribed pharmaceutical alternatives builds on the evidence and a strong evidence which is used internationally and in multiple
can't answer the
countries,
question
peer-reviewed, of medical-assisted treatment. But I think it's important to understand
I
that there's
do
medication-assisted
understand that.
treatment.
Your time is up, and if you could finish your answer, Ms. Sachs, without interruption, then we can move to the next questioner.
Prescribed pharmaceutical alternatives build on a strong evidence base of medication-assisted treatment, where there is a strong evidence base. This is a new and emerging action that's being taken as a suite of action that needs to be closely monitored so that we can learn from it, see and adjust as we need with the evidence and research that we are looking at.
Thank you, Ms. Sachs. Next, Dr. Pawlowski, please, for 5 minutes online.
Hi, and yes, I want to preface my remarks as several other people have done. Let's hope that we can make this a pretty nonpartisan approach, try to find commonalities instead of fighting with each other. I did want to talk about the toxic supply and the safe supply. So I'm not sure if I've got the numbers right, but I think someone said there'd been 1,900 overdose deaths since 2023 began. What percentage of those are narcotics? Can anybody say?
Narcotics. In terms of stimulants, so those are the number of apparent opioid toxicity deaths. I can state that 48% of accidental opioid toxicity deaths also involved a stimulant, and 79% of accidental stimulant toxicity deaths also involved an opioid. So we are clearly looking at a polysubstance, multiple substances, and increasing toxicity. And maybe if you'd allow me just for, if you look at the drug toxicity and the level of fentanyl and the level of contaminants like benzodiazepines and other in our supply since 2016, you will see a significant increase. And so there is a significant change in our drug supply since 2016 that we are adjusting to or responding to.
Now, I know when somebody's overdosed on multiple drugs, they're often synergistic. But what is determined to be the cause of death? Primarily fentanyl? Are overwhelmingly these deaths caused by fentanyl, or how much is mixed where they can't really determine what the cause of death is?
Overwhelmingly, fentanyl is found, and it is fentanyl, but there are a combination of drugs that can be found, but fentanyl in, I think, 80% plus, whether you look at provincial statistics or national, is involved in those opioid toxicity deaths.
Now, it seemed to me one of the issues with safe supply is safe supply. If you're giving people narcotics, it's because they want and are addicted to narcotics, whereas you're saying that a fair number of overdose are by people who aren't specifically getting narcotics. They're doing crack or cocaine that turns out to be laced with fentanyl. So the safe supply evidently wouldn't address that problem.
Alternatives can be for opioids. There are some prescribed pharmaceutical alternatives that can be for stimulants as well. It is not as commonly done and prescribed, but it does exist.
There are in BC, people are prescribing like cocaine and crack?
Or crack, it's a prescribed pharmaceutical alternative, but there are prescribed pharmaceutical alternatives such as Adderall or other medications that could be prescribed. Potentially.
But I would say, though, I mean, a lot of people are going to do crack and cocaine, and unless you're going to provide a safe supply of that, if you're getting toxic drugs because they're cut with fentanyl, you're not going to be addressing that with safe supply, I take it.
I think this is where it becomes important, right? We're talking about prescribed pharmaceutical alternatives, and so it is the health provider that is prescribing and sees what the best interests are and best responding to the patient it has before them, and so working with their client and their patient in terms of what is best to prescribe in that situation.
Now, where does the majority of fentanyl come from on the market?
I mean, there's both fentanyl precursors that come into Canada and are produced in Canada. There is also import, but I will turn it over to Marie-Hélène if she has additional.
Yes, so there, since China scheduled the fentanyl as a precursor, as a finished drug in 2019, CBSA has seen the number of seizures of finished fentanyl decrease dramatically. But on the other hand, the seizure of precursors has increased. And so what we're seeing is with the increased seizures of precursors, we've also seen an increased seizures of labs and super labs. And you will have seen some of the major drug busts that have occurred both in Saskatchewan and in British Columbia in recent months. And what we're also seeing is that there's a number of reports from other countries, I will say Australia, New Zealand, and the U.S., where they are reporting that they are seeing the arrival of finished fentanyl through their borders that appears to be coming from Canada. And so these indicate that there could be a production of finished fentanyl in Canada.
Okay, I'd like to pursue that, but
I think you should pursue getting to the airport, Dr. Pawlowski. Thank you for that.
It's over.
Yes. Monsieur Thériault, 2 minutes et demi.
Mr. Thériault, 2.5 minutes. Yes, thank you. In 2016, during the hearings held by this committee, the Assistant Administrator of Health of BC, Dr. Henry, stated that the approach is not working for opioid addicts, given that the physical dependence on opioids requires a substitute, such as Suboxone, or there have been others mentioned, Vivitrol, for example, leading to recommendation 21 of the committee. A unanimous report, I believe, that the committee tabled in Parliament, and the committee stated that the Government of Canada improve access to prescription drugs to combat opioid addiction, such as Suboxone and other effective medications that aren't yet offered in Canada. In BC, do you have any data for BC on the numbers of substitution therapies or the access to such therapy and how effective it is? For medium term, at least, treatment of specific data for BC. We'll have to follow up and provide you with that. We do have information. I just don't have it right here. Could you provide that information to the committee if you have it? I think that what we have, and I've seen it published before, is up on the internet. BC shows how many people have access to therapy, but do you have any data about the substitute therapies that have been provided? Yes, they do have data up about opioid use and treatment. They have a dashboard that's published in BC showing how many people have access to treatment on a monthly basis. Do you have any idea how many of these medication treatments are occurring across Canada? Because it seems to be a very useful way to lead people to stop consuming the street drugs, the opioids as well, eventually. We know that treatment uses a number of approaches. There are regulatory approaches, but you have nothing on the outcomes, the numbers, and how many of these medical treatments are underway, whether they've been effective or not, what the long-term care is, and so on. what we do is improve access to such treatments, then the provinces and territories do have to take measures of their own, take action, them too. I know that in BC they do have a dashboard up, monthly access. I believe that other provinces do as well, showing how many people are using opioid agonists. But it depends on the province. Not all provinces are making that information public. Thank you, Ms. Sachs. And Mr. Thériault.
2.5 minutes.
I'm going to go back to the need for a national public health emergency. During COVID, we were able to work through jurisdictional barriers constantly, within hours, with provinces, municipalities, and territories, and with Indigenous communities. And we haven't been able to do that when it comes to the toxic drug crisis because of this lack of action. Now, I want to talk about jurisdiction because there's a lot of politics going on here. We have had record amounts of deaths in BC, NDP government, Alberta, Ontario, Saskatchewan, Conservative governments, in the Yukon, Liberal government. 30 states doubled in overdose in the last 2 years in the U.S. The top 10, the majority of them are Republican. This isn't a Republican-Democrat issue. It's not an NDP, Conservative, Liberal issue. This is a societal issue. It's a failure in terms of ideology within society. That's what I believe. We went to Portugal this summer, my colleague MP Hanley and I, on our own dime this summer. We learned what it looked like from a response to a public health emergency. They scaled up on methadone delivery from 250 people to 35,000 in 2 years. They engaged the military to create labs and scale and get it out to people. Is this government looking at an emergency type response? Because we haven't seen it yet. And I really want to encourage everybody around the table here that we need to work collectively, because that's the big win in Portugal was the politicians took off their gloves and they let the experts lead, and they supported them with the resources. That's how they actually got things done. Sorry, it's my time.
So what I would go to, I think it's important that I think it's exactly the information from experts, the advice from experts that informed our renewed strategy, which looks at making sure that we take some short-term urgent actions as well as long-term actions, and that it's an integrated suite of actions that take a compassionate approach. It is, again, we need to look at evidence-based actions, scaling those up. We also need to look at innovative approaches, and when we're taking those innovative approaches, making sure we are working with CIHR, CRISM, and others to look at evaluation of those, learning from those, and implementing those changes, right? And learning from other countries, which we're doing as well.
Ms. Sachs, we still don't have a timeline and a plan with resources to back it up. That's the problem. Without that, we're never going to get there.
I think this
It's piecemeal. It's not working. Incrementalism kills in a health crisis. So does disinformation.
I think that's exactly why with this renewed strategy, we are looking at integrated action. We are working with our partners at infrastructure of how we can better collaborate in terms of making sure that there are housing supports as well. It's not just the health supports, right? And how we are working with Indigenous Services Canada and making sure that we can scale up our actions, that we can have integrated action. I think with the renewed strategy, there are funds that have been allocated through Budget 2023 that are clearly there. And then in terms of timelines, we've taken specific kind of call for proposals for the SUOP. Maybe I can turn it over to Shannon now to speak a little bit about the prevention
I'm sorry, Ms.
actions.
Gennard, that we're well
Fine, I'm
past
missing it
time.
again.
We're going to move now, I believe, to Dr. Kitchen. Mr. Majumdar,
Thank you.
5 minutes.
Appreciate it. Thanks for being here. I wanted to pick up from some of the questions that my colleagues had earlier. So I'll kind of get to the point. How many minutes do I have? 5. 5 minutes, great. Well, in September, you had received letters. In October, you'd received letters from leading clinicians. Why are you not meeting with them?
I think we're meeting with a range of experts.
Except people who are proactively reaching out to you, dealing with opioid addictions.
We are interested in meeting with a range of experts with a range of different views, understanding that and making sure that our actions moving forward can be grounded in data and evidence, and that we have a better sense of how to inform those moving forward.
Thank you for the answer, but you're still not answering the question. Why are you intentionally deciding not to meet with these ones?
We are happy to meet with a range of people and experts with differing perspectives.
Perhaps the ones that you agree with and reinforce your thesis, or ones that have a constructive, critical perspective that might be acted upon?
All views are important for us to be considered.
Except for these people who've been reaching out to you multiple times and you haven't taken the time to meet them.
We've met with and will continue to meet with people who have a range of different perspectives.
You
to
haven't met
inform
with
our
these
actions
ones. They
forward.
haven't even heard from your office. And I don't mean to come after you specifically. I mean, it's the minister as well, who the letter was addressed to, that hasn't been reaching out or responding to this. So I'm frustrated because, you know, I have to ask the question, would you, as a professional, agree with these leading clinicians that a whole new group of people are becoming addicted as a result of this failed policy of unsafe supply? Would you agree that that's a possibility?
We are hearing a range of concerns and issues. That is one of the concerns we are hearing. I think that's why we are taking a number of actions, including looking and re-reviewing the diversion, kind of prevention and risk mitigation protocols of different programs, why we're engaging with a range of experts, with a range of views to better understand the data and evidence to inform our actions moving forward, and doing evaluations.
It's the same answer you've provided for a lot of my colleagues already, and I wanted to take up, you know, Mr. Hanley's perspective on actually just getting to some facts here. Would you agree that it's in the realm of the possible that this policy is creating a whole new class of addicted people?
You're asking me a hypothetical question. What I'm saying is that
It's
we
not a
are
hypothetical
looking
question. It's
at-
about whether this falls into the range of inputs and evidence that you're considering, or is it not being considered as evidence?
We absolutely take the concerns that we are hearing seriously, and that's why we are taking a range of actions that I've mentioned.
Let me ask this. How many Canadians have died of opioid overdose since Health Canada started funding unsafe supply sites in 2020? A simple question. It's a policy that started in 2020. How many people have died as a result of this policy?
We have information on opioid toxicity deaths across Canada, and as you know, there are a range of actions that are being taken by the federal government, by provinces and territories, by community groups to reduce and address.
I can tell you the number, which should be carved into the desk of every person working on this, from the minister's office down to the analyst. It's 23,823 Canadians who have died from a policy that has not been even proven, whether or not as an experiment or otherwise, to be effective. It's been dangerously ramrodded as a matter of ideology onto Canadians, and now we have a national crisis, which the government won't even, as my NDP colleague has said, admit is a national crisis.
What's been taken is a range of action, which includes prevention, harm reduction, treatment, enforcement actions. So there have been a range of actions that have been taken over that time in cooperation with others. I think we all see that there continues to be a crisis, and we absolutely need to take action. So that's why we're looking at how do we scale up where there's strong evidence, where there's promising practices, where there's promising community-based actions, and trying some
So
innovative
let me just ask
actions as well.
what Mr. Hanley had presented earlier. Let's just, I'm not trying to be gotcha moments or catch you off script here. It's just, do you professionally think that this has been working?
I professionally think that we have some evidence-based actions that have been put in place. We know that supervised consumption sites have saved lives. We know that naloxone has saved lives. We know the information drug checking has provided. We know that opioid agonist treatment is used worldwide and is the first line of
this
response.
appears to me
we know
to
that
be-
there's prevention actions. So there are a range of actions that we know are effective.
This appears
There's
to
also
me-
innovative actions that are
Forgive me,
new
I
that
think
we
the
need to build
convention
the
of the
evidence.
committee is that we take equal amount of
Apologies.
time.
And you had your 5 minutes, and it's now up.
Oh, well, thank you. I appreciate it. Thanks for your time.
Next is Ms. Sidhu, please, for 5 minutes.
Thank you, Chair. Thank you, all the witnesses, for being with us. My question is to Dr. West or Dr. Hurley. A toxic drug supply that is literally poisoning people to death. Can you expand on why supporting harm reduction measure is so important to stopping the ever-rising death toll, the opioid and toxic drug supply crisis? Dr. West, you can start.
Thank you very much for the question.
Um, I think it's important to recognize that harm reduction is one of a spectrum of approaches that have been scientifically proven to be critical in tackling the toxic drug crisis. And we've heard this morning of a number of the different approaches to harm reduction, of which prescribing practices, including safe supply, are one of them. However, the evidence also provides us a clear sense that harm reduction without treatment services is less effective. Treatment services without harm reduction are less effective. And if one wants to actually make inroads to the toxic drug crisis that exists today, we have to invest in the full spectrum of services, from prevention to harm reduction to treatment and recovery services. And that's where perhaps the scientific community, beginning in about 2010 and 2015, where we went from a crisis of opioid overdoses to the fentanyl toxic drug crisis, has stressed over and over again that communities need more resources to treat the toxic drug crisis.
And thank you, Dr. S. Can you explain the various risks of forcing somebody who's not ready into treatment? Ms. Sachs or Ms. Hurley, you can explain on that.
Go ahead. Okay. I'm happy to respond then. Again, I think seeking treatment for substance use is an individual choice for people who use drugs, and involuntary treatment can exacerbate stigmatization and can be a barrier to accessing life-saving services and life-saving care. So I think really what we've been supporting is making sure that there can be evidence-based, person-centered, trauma-centered supports, including treatment, when and where people need them. That is not currently available across all of Canada, but certainly what we are looking to invest in, some of what we've been doing through our community-based programming with SUOP and others.
You just recently said naloxone is a vital tool in harm reduction for drug crisis. We also heard the opioid overdose crisis primarily affecting male 20 to 59. What kind of awareness education campaign can be done to help these demographic?
For that question. That's an excellent question. So certainly, for men in trades, as I mentioned, we've been funding and investing specifically in an Ease the Burden campaign, and that raises awareness and harms associated with the use of opioids and other substances, as well as stigma, especially for men in those physically demanding trades, right, to be able to access and be able to speak about their concerns. And between September 2022 and March 2023, traffic to that campaign web page exceeded 142.7 million views. And so, we know that we can raise that awareness and kind of stigma reduction. We're also looking at prevention, though, in youth. And so we do, teens and young adults at festivals. Happy to turn it over to Shannon to speak more about prevention efforts that we are undertaking.
Yeah, I'm happy to add Public Health Agency of Canada really aims our public education efforts at specific audiences. So we recognize how important it is to reach people with messages that resonate with them. So we've developed messaging with youth, for example, about different substances. So I know we're here today talking about opioids, but reaching youth on substances that youth are especially using in Canada, alcohol and cannabis, for example. We have other messaging for older adults, for pregnant people. So just recognizing the importance of reaching people with messages that work for them.
Can you developing it with them, right? I think as Shannon mentioned is critical, and when we've developed our Ease the Burden campaign and other, it was really essential that we work with people who have lived and living experience so that it resonates with them.
Thank you. The Canadian
Thank you.
Association.
Sorry, Ms. Sidhu, that's your time. Next, Dr. Ellis, please, for 5 minutes.
Thank you very much, Chair. Question, Ms. Sachs. When Purdue Pharma supercharged the distribution of OxyContin starting in the United States, it's generally accepted that was a bad thing for society. Is that correct?
I think there are, there were concerns then in terms of how, at the beginning of the opioid crisis and prescription of opioids and the implications that that had.
Sorry, Ms. Sachs, I'm just going to interrupt you there, but isn't it true that the Sackler family of Purdue Pharma was sued by the U.S. government for billions of dollars for that action?
Correct.
Thank you. So that would mean it'd be a bad thing, probably.
Well, there were many
Simple yes or
concerns,
no.
including the Canadian government has expressed concern. Absolutely. There were
Okay,
concerns.
thanks. So tell me this then, why is it a good thing that the Canadian government is now giving people 30 tablets of 8 milligrams of hydromorphone for free?
Canadian government is investing in certain programs, which includes prescribed pharmaceutical alternatives as one of a suite of measures. And I think
I'm aware of what they're doing. I'm just trying to get you to answer the parallel. It's quite obvious. When Purdue Pharma did it for money, it created a public health emergency. When the Canadian government gives these drugs away for free, we think it's okay.
Canadian government is looking at providing a range of services. As I said, often these programs are part of a suite of services so that individuals can connect with primary health care, mental health services, housing, job training. It is creating a connection to health and social services and supports.
Ms. Sachs, all of that stuff makes perfect sense. Giving it away for free doesn't. The other question I would ask you is, on Canada.ca, it says a few grains of fentanyl can be enough to kill you. Is that true?
That could be true, yes, depending on
It
someone.
could be
so
true.
it's
It's
how
on the
it
Health
is.
Canada website.
Yes,
It must
it
be
is.
true. Is it there or not?
Fentanyl could, in certain
A few
quantities,
grains could kill you.
depending on-
I'm going to badge
Yes.
you a bit on this because it says right on your website.
Yes,
Thank you. Wow, that took a lot. Tell me this then. What sense is there to decriminalize 2.5 grams of fentanyl? If a few grains could kill you, what sense is there in that?
I can add. First of all, I think in the exemption for BC, it is clear that trafficking of drugs, so if that is pure fentanyl, right, any trafficking of drugs remains illegal, even under the 2.5 grams. And so when we are talking about the exemption BC, we are talking about the personal possession, personal use of a total of 2.5 grams, which will include, other substances that can be cut with whatever, the substance that they are using.
Thank you. I mean, I understand all that, but let's talk a bit about amounts. Let's say, from some American data, I used other data previously, but a lethal dose is as little as 0.25 milligrams. That means 2.5 grams is enough to kill 10,000 people. 10,000. Now, we had the minister here before. Oh, it's cut with something. Let's cut it in half. 5,000 people. Let's cut it in half again. 2,500. Let's cut it again. 1,250 people. That one person is allowed to carry. Is that appropriate? Simple question. Is it appropriate or not?
The threshold that was used in BC was developed based on a range of factors, including patterns of use, the data that we do have, including from law enforcement. There were a range of factors that were considered to establish a threshold. It is a cumulative 2.5 grams. And as I mentioned, trafficking, even below the 2.5 grams, remains illegal.
Thanks. I'm not talking about trafficking. I have one final question. We talked about the addiction medicines experts who requested to meet with Minister Sachs, talking about this is not harm reduction, it is harm. It's not safe supply, it's reckless supply. It is reckless. It's reckless for people suffering from addiction, it's disregard for our communities, and there's a complete failure of monitoring, supervision, and abrogation of responsibility. Will the minister agree to meet with these physicians who wrote this letter?
I can't speak on behalf of the minister. What I can
Will
say
your
is that
department meet with them then?
we are happy to meet with a range of
that's your
experts
time,
with
Dr.
different
Ellis.
perspectives.
Go ahead and answer the question. Take 20 seconds if you need
I
it.
can say on From a departmental perspective, as I mentioned earlier, we are happy to meet with a range of experts and differing perspectives to better understand concerns, risks, and benefits with current actions that are being undertaken.
Thank you. Mr. Fisher, please, for 5 minutes.
Thank you very much, Mr. Chair, and thank you folks for being here. I want to ask Dr. Weiss if he could maybe give us a little bit of background on early response to safer supply.
I'm sorry. When you say early response to safer supply, I'm not sure I understand the question.
Early results, a little bit of early data that you might have on the safer supply program. I think that maybe it would be good for us to understand and maybe to get clarity on tragic opioid deaths, fentanyl, and as it might relate or may not relate to safer supply.
Yeah, so we've funded an arm's length study through the Canadian Research Initiative for Substance Misuse on safe supply programs in 11 sites across the country. The early research results coming out suggest that in highly marginalized clients, those who have limited access to health services, safe supply is helpful and effective in reducing cravings, reducing time on the streets, and reducing deaths. However, it's also been shown that it works best when wraparound services are also there as well. And the critical element is that with wraparound services, clients are then expected to attend and participate in allied health and social services. That's when safe supply is most effective. I'll also mention, of course, that safe supply, as I said before, really is part of prescribing practices overall, which led to the situation we're in today, starting in the early 90s. And the term diversion is also not new. It's something that's been around since the 90s because of prescribing practices. And when prescribing practices were curtailed, that's when more people went to the streets. And at the second wave of the opioid crisis is when people could no longer receive prescribed opiates. They went to the streets and they started to overdose on heroin. And the heroin, which was the second wave of the toxic drug crisis, was then supplanted in 2013, approximately 2010 to 2013, when fentanyl arrived for the first time, took over from heroin, and became the drug of choice on the streets, where very small amounts leads to overdose deaths. So I think it's important to note that when we speak about safe supply, we're talking about part of a range of prescribing practices, good and bad, that have been part of how this crisis began in the first place, but have to be considered scientifically as part of the go forward regardless, because it is one of the sole prescribing of opioids, one of the sole approaches that we have right now for treating chronic pain and cancer pain.
So then just to sum up that experts believe that it has to happen within a suite of different actions to be successful?
Correct. Well, different actions, but most importantly, within allied health and social services that seek to tackle the social determinants of health, seek to tackle the needs of individuals to be able to attend to other elements that are causing them to seek opioids for both trauma and pain reduction.
Thank you. Do I still have time, Mr. Chair? Okay. I would like to ask the folks from ISK. Ms. Sachs spoke about the disproportionate impact on Indigenous peoples. Can you talk a little bit about culturally safe and trauma-informed supports?
Yes, I'm happy to do so. I think what is clear is that Indigenous people in this country are disproportionately impacted by this crisis. In BC and in Alberta, you're looking at 5 to 7 times the rate of non-Indigenous people. And so For us at Indigenous Services Canada, we're really trying to connect people to services, connect people to harm reduction products, whether that's naloxone, but specifically opioid agonists, which we've been talking about today. We've been trying to access wraparound sites, basically 82 sites across the country delivering opioid agonist treatment in over 100 communities. We're also trying to get mental wellness teams, and Jennifer Sachs mentioned that continuum of services, and those mental wellness teams are there. There's 75 of them serving 385 communities across the country. And what we're trying to do there is get people to go through withdrawal management first, to stabilize people first, and then move them through opioid agonist treatment, but also on the land training, healing centers, connecting them with culture, and really what comes after. After you've gone through your treatment, what can we do to support people in a more longitudinal way? And so we're really looking at innovative systems. We have an interesting pilot right now happening in Ontario, where because most Indigenous populations are in rural and remote, we are trying to connect them with new virtual supports. Those Oculus lenses are one of them where people can have access to wraparound services.
Thank you. We're well past time. Monsieur Thériault, 2 minutes et demie, s'il vous plaît.
2.5 minutes, Mr. Thériault. Dr. Weiss, I decode from your prior answers that from a scientific point of view, harm reduction must remain the central pillar of the strategy, yes or no?
One of the pillars, I would say, not more important than treatment. It's one of them.
En fait.
So, if we had simply repressed supply, we would probably have more deaths than we see at present. Is that the case?
Sorry. Did you mean prescribed opiates, or did you mean supply on the street itself? I'm sorry, I didn't understand when you said repressed supply. I'm sorry.
Je dis si.
Yes, well, if we hadn't taken the harm reduction approach, scientifically speaking, are we able to say that there would be more deaths than we've actually seen so far?
Vous êtes d'accord avec ça?
Absolutely.
OK.
Absolutely.
Maintenant, il ne restera pas beaucoup de temps.
Very well. So I haven't much time left, but what should we do better, or what is the problem with the current strategy? How shall we improve it?
Well, what I would say is what we've heard from experts for many years, and that is there has to be a coordination of care within communities. The communities have to play a critical role in this because that's where the problem is happening. And it's different in different communities. In Western Canada, opioids. In Eastern Canada, amphetamines are a much bigger problem. The commonality is that they're all contaminated with fentanyl, and a lot of that contamination with fentanyl is coming from organized crime that is actually delivering that contamination within the country. That said, we need a coordination of care. We have to overcome the fact that there are very little resources being provided for treatment and harm reduction. We also have to combat the social determinants of the societal ills that are actually driving people to addiction. And critically important, the stigma of illicit drug use is still overwhelming, including within the health system and within government itself. Till we destigmatize, we have a significant challenge.
Thank you, Mr. Weiss. Next, Mr. Johns, please, for 2.5 minutes.
2016 to 2021, we saw opioid toxicity deaths double, and here in Canada. Would you consider that a failure? Just a simple answer.
Consider a public health crisis.
Yeah. Okay. In the U.S., it went up 279%, more than doubled. And there was no safe supply. Many states didn't have safe consumption sites. Would you consider that a failure?
I think having those harm reduction are life-saving services, absolutely.
So we're not seeing a lot different, in terms of the amount of deaths that, in terms of policies, we've seen a failed North American strategy, really. We can look to Portugal, where they had 100,000 chronic drug users in the height of their crisis. Now they're down to 22,000. They had over 70% of HIV transmission was through intravenous drug users. Now that's down to less than 2%. Would you consider that a success story?
I think the comprehensive approach that Portugal took is absolutely a success and is something that absolutely informs our way forward.
Right. So, I can look at safe consumption sites, for example, supervised safe consumption sites. How many people have died since since Inside opened 20 years ago at a safe consumption site?
There's a tricky answer. We have data on federally authorized supervised consumption sites. We issue as well exemptions, so provinces and territories can set up their own urgent public health needs sites, often known as overdose prevention sites. My understanding is that there has been one death at a BC overdose prevention site, but apart from that, I am not aware of any deaths at any federally authorized supervised consumption site or any other overdose prevention sites.
And it would sure be hard to keep track of how many lives have been saved, but we know it's in the tens of thousands. Lethbridge closed their supervised consumption site in 2020. They had 77 deaths last year in the whole year. Already, August 31st, they've had 94. Do you believe that the closure of their supervised consumption site is contributing to the cause of death in Lethbridge, Alberta?
I think I can say supervised consumption sites are absolutely a life-saving service, and we have data around that.
Would you call that a failed policy?
Again, I think having a suite of services, including harm reduction measures like supervised consumption sites, has been shown to save lives.
I mean, I think the numbers speak for themselves. 94 people have died since by August. They had already surpassed last year. How much time do I have, Mr. Chair?
None, but you have time to answer.
I've provided the responses, really the importance of having that suite, including harm reduction measures that save lives, and its supervised consumption site is one of several evidence-based harm reduction actions that can do so.
Thank you, Ms. Sachs. Mr. Doherty, please, for 5 minutes.
Sure. Of the overdose deaths that we know of, are we familiar with, or do we know the amount through autopsies? How many of those drug users tested positive for fentanyl? What's the percentage?
We have toxicity, and I think I had mentioned earlier, I think it ranges for each year, but it's over 80% involved fentanyl.
So probably 90%, I think, is the number that I know of.
Sorry, I was quoting.
Of the 38,000 since 2016, it's been 38,000 since 2016. Would it be safe to say, because of the stigma surrounding drug use and addictions, that number is likely considerably higher? And the population base, homelessness and what have you, so those numbers, many of those deaths are not reported, go unreported?
Say that's the best data that we have. Certainly our public health agency colleagues work with coroner services and provinces and territories across the country to collect that data. I don't know
It's feasible to say, again, I realize it's hypothetical, but it's feasible to believe that that number is likely quite a bit higher. It's like, you all know the work that I do in mental health. So suicide, we know that those numbers are likely higher because of the stigma surrounding that. Many of those deaths go unreported. Could the same be said with these overdoses?
I think it's the best data that we have. It is possible that there are additional deaths.
And to anybody that's on there, short answer again, of the billions of dollars that we're spending, the government recently announced upwards of $20 billion of spending through the substance use and addictions programs. What percentage of that money is going to data or data collection?
So there's, data is collected through a variety of different
But specifically that money there, what's the percentage that's going to data?
So in budget 2023, I can specifically speak to the fact that we were investing over, and I just want to make sure I have this, 50.8 million over 5 years, starting in 2023, to the Public Health Agency as well as other for vital data collection.
How much of that money is being spent on recovery?
recovery is part of a suite of services and supports that are provided, and so there's transfers that we have made to provinces and territories. As you know, health services are largely delivered by provinces and territories.
Would you agree with me, though, with the statement that the billion dollars that we spent to date fighting this crisis isn't working? So if we don't have a targeted approach with this 20 billion, we're just throwing more money at an issue, and you were going to be before this committee in another year or 2 years or 3 years with the same issues.
I think there are areas where data and evidence is absolutely critical to understanding what is effective, what is working best or not. And I think Dr. Weiss, spoke to specific, details around some of where we are collecting that data.
What are the metrics that are being used by the Public Health Agency of Canada to gauge the success of the programs that we have?
So there are a variety of different indicators. I can turn it over to Dr. Weiss because there's a number of evaluations that we have underway, and he can perhaps speak to some of the specific indicators and ways that those are being evaluated.
Would you say it's a success at this point?
I think there are areas
If
where
the numbers
we
are
have
doubling
evidence-based.
and getting worse, are we succeeding?
What I could say is there are certain interventions where we have collected data and we see that there's an evidence base that there is absolutely lives being saved. There are other areas
So
where we
of
are
those-
learning and adjusting.
Okay.
But
Of
collectively,
the lives that are being saved, so that is if there's an overdose and we know that we saved a life, do we know if that person has overdosed again, or how many, I'm trying to find the right word, have they re-overdosed? What's recidivism, or what's the word I'm looking for, I guess? How many of those lives that we calculate, that Canada calculates and says we've saved over 75,000 lives or 50,000 lives, how many of those lives are still alive today? How many of those Canadians are still alive today?
I don't have a specific number for you. What I can say is that's exactly why we are looking at a suite of services and support so that we can ensure that people have access to treatment when and where they need it, when along their journey that they're ready. So we know that some people will go into treatment and then relapse. We know that some people will have access to life-saving services and then continue in treatment. So we need an integrated approach, a compassionate approach, which is exactly what the government has done in its renewed strategy of making sure that we have a full suite of services.
I agree
and
with
we all
you.
need to work together
That's your time,
to be
Mr.
able
Doherty.
to deliver that.
Thank you, Ms. Sachs. Next, Dr. Hanley, please, for 5 minutes.
Thank you very much. And before my questions, I just wanted to give notice of motion, and that will be the intent of the motion is to have the minister appear as part of this study, and so the motion will be as part of its study of the opioid epidemic and toxic drug crisis in Canada. The committee invite the Minister of Mental Health and Addictions and Associate Minister of Health for 1 hour, and that meeting take place no later than Monday, February 19th, 2024. So I'm presenting that as notice of motion. In terms of questions, first of all, I just wanted to make a couple of comments. There are, again, a lot of we're hearing a lot of focus on safe supply, on the assumption that safe supply as a concept doesn't work. We know that there has been diversion of safe supply. That's certainly been documented, at least anecdotally, by some of the experts who have written letters. But we also know that diversion has always been an issue, and for many years with prescription drugs as well. So I just want to make the point that diversion of safe supply does not mean that safe supply does not have an important role in the spectrum of approaches. And where there is diversion, we need to do our best to prevent it. I did want to point out that the BC coroner has said, we know for a fact that people are not dying from safer supply, including children. The rates of death amongst those under 19 have not increased at all since safe supply was introduced. And that's within the BC context, a quote from Lisa Lapointe. I also think it's important to talk about some misconceptions about fentanyl and the issue of tolerance. So the threshold for decriminalization in BC were based on expert recommendations. There was a lot of back and forth, as we know, over a period of probably about a year to agree on thresholds, and the thresholds are really based on the concept of tolerance of fentanyl. So people who are addicted to drugs become tolerant to incredibly high doses very rapidly, and that is the rationale for the concept of using thresholds to determine decriminalization. In Portugal, as Mr. Johns has referred to, we had an incredibly educational trip to Portugal together. The concept of personal possession in their decriminalization is 10 days of supply of whatever drug that is determined. So the thresholds are based on a 10-day supply. So we forget that in this discourse that criminalizing drug use is not only not working, but is actually causing harm because the market is being flooded with ever more dangerous and toxic drugs. And criminalization adds to the stigmatization that prevent people from accessing care. So for my conservative colleagues, I would ask, why would we, or should we keep pursuing policies that are clearly not working? So in my remaining time, which I am actually not sure how much time I have,
Just about a minute and a half.
a minute and a half. I wanted to finally give Ms. Hurley the floor. Okay. I thought I was giving notice. Okay. Then I will. Then in my remaining time, I will actually. Would it be in order, the chair, Mr. Chair, if I were to move that motion to have the minister appear?
Subject to the motion is the study that we're presently doing, so notice technically is not required, and it would be in order for you to move the motion.
I understand. Oh, okay. Then I would like to move the motion as I had previously read.
Okay. All right, the motion is in order, and the debate is on the motion to invite the minister prior to February the 19th. Discussion. Seeing, okay, Dr. Ellis and then Mr. Doherty.
Thanks very much, Chair, and thanks to my colleague for the motion. I certainly think that February 19th is a long way from now. I would suggest to you that a friendly amendment might be something in the order of January 15th. We do have some time available to us, and this is an important study. I think my colleagues all recognize that. And I would suggest that continuing to delay this important study by not having the minister appear until February creates a significant time delay and an allowance of policies that we know are, as my colleagues have clearly mentioned, that these policies are not working, and allowing them to continue and allowing the minister to not be suggested to meet with physicians who have a significant difference of opinion related to safe supply, in quotations, I think is dangerous to Canadians. And obviously we know that officials from Health Canada nor the minister have met with physicians with a contrary point of view. And we also know that the government doesn't have data, doesn't have a plan either, didn't have one from the very beginning. So I think waiting till February 19th will continue to put Canadian lives in danger and in jeopardy. And for that reason, I suggest we need to move this change the date to January 15th as an amendment, Chair. Thank you.
Okay, so we have an amendment to delete February 19th and replace it with January 15th. So the debate is now on the amendment. Mr. Doherty, please.
Well, I would agree with my colleague that sooner rather than later. That goes to the same comment that I was going to say to Mr. Hanley's motion. I think it is important that we have the ministers here, although I do believe we're going to get the same gobbledygook that we received previously, that they don't they don't know their file. They don't have the data. So I'm not quite sure the benefit that we're going to get out of this, of having them there, other than holding them accountable. Probably walk out more frustrated than we are when we walk in. Mr. Chair, I just want to offer through you to my colleague across the way and my colleagues across the way that I think waiting till February 19th is too long. I think we would like to get on this. While it might have been Mr. Hanley's motion, it was Conservatives that pushed to get this the study going sooner rather than later. And so I would ask the committee to consider early January dates, if not additional times within the next 2 weeks, that we might be able to meet with the minister, so that we can get on to we can do the good work that we're doing and get on to other projects. Thanks.
Mr. Fisher, and then Mr. Johns.
Thanks very much, and thanks, Brendan, for moving the motion. I think we can all agree that we definitely would like to have the minister here, and I'm sure the minister wants to be here for this. We don't sit in January. We only sit until the 15th or 16th of December or so. Would Dr. Ellis be willing to say no later than February 2nd? We get back here the 29th. So could we say no later than February 2nd? That way it could be the first meeting that when we come back in the new year.
Mr. Johns.
I'm actually good with that. And if necessary, like if the first week doesn't work for the minister, then we meet in before the House comes back. You know, if that needs to happen. But I think that's reasonable. It meets everybody halfway.
Okay, I see nobody else. I see Dr. Ellis.
Well, thanks, Chair, and thanks to my colleagues. You know, I think that, certainly we've been able to meet at times outside the regular sitting schedule on other occasions. I think that everybody clearly knows, every Canadian out there watching, every person around the table knows very clearly that this is an incredibly important issue to Canadians. And having a meeting with the minister during time which we are not sitting is not setting any new precedent. It's not something that's unusual. And in a case that is incredibly important, I think that ask is very reasonable.
Mr. Doherty?
I would just challenge our colleagues around the table. Mr. Johns, you've been up a number of times in the House, as have I, over the last 8 years, talking about this national health crisis that we have. Why don't we treat this as the crisis that it is? And I think there's nothing stopping us from coming early into Ottawa or doing it remotely. Whatever is needed. I don't know why there's a hesitancy to try and meet as early as we can in January, if possible, prior to us coming back.
Mr. Fisher?
Thank you, and I agree. No later than February 2nd does not presuppose it couldn't be sometime in January an extra meeting. I have no issue with that. If we stick to no later than February 2nd, we'll work with the chair, can work with the minister's office on getting that set up.
Okay, I see no one else on the speakers list. The amendment moved by Dr. Ellis was to replace February 19th with January 15th. There's a discussion around February 2nd, but we can't amend the amendment. The appropriate thing to do is defeat the amendment, move a new amendment, and adopt it if that's the will of the committee. So there's no one further on the speakers list, so we're ready for the question then on the amendment, Dr. Ellis's amendment. Go ahead, Dr. Ellis.
I'd like to request a recorded division, please.
So a recorded division on the amendment for the date change to, instead of saying on or before February 19th to No later than, sorry. So the wording of the motion indicates the appearance of the minister would take place not later than February 19th, and what we're voting on now is to change that February 19th to January 15th. Madam Clerk, if you could do a recorded division on that, please.
Mr. Fisher,
No to the amendment.
Mr. Hanley,
No.
Mr. Juari,
Oppose?
Mr. Pulaski, sorry, could you repeat that?
No.
No. Ms. Sidhu,
No to the amendment.
Mr. Ellis,
Yes, of course.
Mr. Generu,
In favor.
Mr. Doherty,
Yes.
Mr. Majumdar,
Yes.
Monsieur Thériault,
No.
Mr. Johns,
No.
7 nays, 4 yeas.
The amendment is defeated. The debate is now on the main motion, unamended. Mr. Fisher.
Thank you, Mr. Chair, and again, in agreement with Mr. Doherty, perhaps we could say no later than February 2nd, which again doesn't presuppose us not meeting sometime in January rather, at the will of the ministers, or the ability of the minister's office and the work of the chair.
Okay, so that amendment is now in order. The debate is on the amendment. Anybody wish to intervene on the amendment? If not, we ready for the question? The question is that the motion be amended by deleting February 19th and replacing it with February 2nd. All those in favor of the amendment, hands please. It's unanimous. The debate's now on the main motion as amended. Any interventions? All those in favor of the main motion as amended, it's unanimous. The motion is adopted. Thank you, Dr. Hanley. That's your time. Where am I? Doherty, Pawlowski. Over to the Conservatives. Is it, who's next for the Conservatives? I lost my place. Mr. Majumdar, you have the floor for the next 5 minutes, sir.
Greetings. So we were discussing earlier what was some of the basic facts around this policy of safe supply. Maybe one of the things I could take a look at here is the diversion of hydromorphone to the black market has had massive impacts. What kind of impact did it have on prices that you are aware of?
I think, as I've mentioned, there are a number of concerns that have been raised. We are listening to those who have differing perspectives on prescribed pharmaceutical alternatives. We are also looking at the data and we are evaluating these programs, as is BC. And so certainly this is information that we are looking to get additional information on and better understand the implications of and how much diversion is going, what are the risk mitigation measures we can be putting in place, what are some of the best practices. Certainly, I can note that in terms of actions we've taken from Health Canada, we are reviewing and working with our programs to look at those risk mitigation programs or protocols, I should say, and get a better sense of those.
If we could dig a little bit into the substance of what you're providing here. When you are going to look at the impact on prices, what methodology are you going to employ to find out how government-provided hydromorphone has depressed black market prices?
So from where I sit, we work with experts in evaluation and experts in this field to undertake third-party evaluation of these programs. And so certainly I'm happy to turn it over to Dr. Weiss to look at some of what is being looked at in terms of the current third-party evaluation of some of our prescribed pharmaceutical alternative programs.
For the evaluation, if I may, for the safer supply, the most important questions that have been asked as part of this research is the benefit to people receiving safer supply. And the funding for this research did not include specific questions around diversion, which is more of a criminal justice matter than it is a health matter, vis-a-vis determining whether or not people receiving safe supply have improved health outcomes. So I can't really comment on the matter.
Did Portugal experiment with the fentanyl crisis?
To my knowledge, is not experiencing a public health crisis with relation to fentanyl. When they put in their public health approach, they were really facing a crisis in terms of heroin.
Did they have the supports in place prior?
They put in a range, a comprehensive suite of services and supports.
Did Canada?
That is exactly the renewed Canadian Drugs and Substance Strategy specifically speaks to, and previously as well, but really right now, putting additional focus on taking an integrated, holistic approach, which looks at prevention,
No, I appreciate what you're saying,
which looks
but
at harm reduction, which looks at treatment,
did Canada
which looks
do
at
it in
recovery.
advance? Or
Canada
did it do it
has
in
been-
response to a failed policy?
I think we are looking to continuously improve our response, and that is exactly why the minister announced the renewed Canadian Drugs and Substances Strategy at the end of October, to look to continue to
I
improve.
don't think
and
it's
have
fair
more
to
great
suggest, I mean, let me know if it's your professional opinion to believe it's like comparing apples to apples.
To compare what with what?
The
Sorry.
Portugal experience, the model, and the Canadian model.
I think we look at a variety of different international experiences. We also look at our Canadian and the specific crisis we are facing in Canada. I would say the U.S. is most like what Canada is facing right now in terms of the drug toxicity. But we do look at best practices internationally as well to inform our approach.
Have you had a chance to meet with the Portuguese officials?
We have met with Portuguese officials, as has other previous officials who have been. So I personally have not gone to Portugal, but have met with Portuguese other colleagues internationally, and we have had other colleagues of mine who have met with Portuguese
Are
officials.
they presently experiencing an epidemic?
They continue, they take a range of actions. I can't speak to the specific drug toxicity that they are facing, but it is not the same drug toxicity crisis that we are facing in Canada in terms of fentanyl, in terms of contamination with benzodiazepines and other substances. And I think, as was mentioned before, in Canada it is quite complex. It's not the same. We talk about an overdose crisis. What people and, the substances that are being consumed
Have they seen
in
an
BC
increase in
versus the Maritimes
addictions?
versus the prairies.
That's your time, Mr. Majumdar. Finish your answer, Ms. Sachs, then we're going to move on.
There are regional variations in terms of the drug toxicity and the substances that people consume, which is important in terms of how we respond and in terms of the health and the public health response that we take. And that's also why we need to be looking at community-based and working collectively together to address and specifically targeted responses.
Thank you, Ms. Sachs. Dr. Pawlowski, please, for 5 minutes.
Dr. Weiss, I wanted to ask you a question. So in response to an earlier question, you made a kind of an interesting response. You said with respect to the early data, it showed that for those highly marginalized people, a bunch of parameters had changed, including lower death rate from overdose. You didn't say with respect to those people who were not highly marginalized. And so what are the numbers with respect to people who aren't highly marginalized?
Unfortunately, the numbers are vanishingly small because currently the safe supply programs are small in number and small in numbers of people that are actually receiving safe supply. So in the majority of cases, these are people in marginalized communities who've been seeking the safe supply. And the other issue, of course, is that we don't have an accurate number of the total number of people who are using substances and what type of substances they are. But this is something that we are going to be undertaking in some new research studies. In other words, if we're going to actually intervene, whether it's through services of one sort or another, we need to be able to not just understand the numbers of people who are receiving treatment, we also need to understand the total number of people who are using substances. This is part of the research that is going to be undertaken going forward. So If more people can access a full suite of services, we'll have a better idea of the trends over time of improved outcomes for people who are addicted to opioids and other illicit substances.
Okay, so maybe even if the numbers are small, and you said the vast majority of people that are getting safe supply are marginalized, you didn't say no people who are not marginalized were getting it. So is there any numbers for those who are not marginalized, and what's that showing, even if the N is small?
Again, I think the data to date on safer supply suggests that anyone who receives it together with allied services is at a lower likelihood of overdosing and having adverse outcomes to street drugs.
Okay, and let me turn to decriminalization. So Portland, I think Oregon in 2020 passed through referendum measure 110 that eliminated penalties for possession of small amounts of drugs. Now, in the 2 years since, and this is according to Globe and Mail's numbers, the number of overdoses in the state have increased 61% as opposed to 13% across the United States. Like, what is Portland doing wrong? And in comparison, Portugal seems to be doing better. What can we learn from Portland?
I can't really speak to comparing, contrasting Portland and Portugal at this point. What I can say, and I think it was discussed previously, is having in place community-driven, comprehensive wraparound services for people who use substances is critically important when we look to begin to destigmatize drug use, which decriminalization is really part of an effort to destigmatize and to direct people who use substances to the healthcare system. But we need a healthcare system that treats addiction as a public health challenge and allows people to have access to those services in a user-friendly manner. We're definitely not there yet. We do not have adequate access to services. Without that, a lot of the efforts that are being made, which may be effective, will be less effective until the allied services are available.
And if I could just ask the same question to people who are actually there, is that the problem with the Portland system, and is that the problem so far with our safe supply system, that we don't have adequate treatment for those who are addicted?
Okay, there we go. So again, I don't think I'm well positioned to speak specifically to the Portland statistics. I mean, there's a variety of different issues and a specific, there's context around that. In the Canadian context, I think Dr. Weiss really captured it, that we need to be able to have a range of services available for people when and where they need it. And so that's life-saving services, connection to health and social services, those wraparound. And when they are connecting, it is some of those health, it is housing, it is food security, it's a range of services to support people through their journey. And we know that people, they need to have access to treatment, but they may relapse, they may come in and out. And so we really need that comprehensive allied suite of health services, as Dr. Weiss mentioned.
Thank you, Dr. Pawlowski. Ms. Sachs, suite M. Thériault pour 2 minutes et demie.
And then Mr. Thériault for 2.5 minutes. Yes, to conclude for today, I imagine this is the last time I'll be up with a question. Since the outset of this, we have discussed the fact that the provinces and territories, Quebec included, who have jurisdiction over their provinces and territories with regard to policy and for implementing an action plan when all is said and done. So is the level of collaboration good between the levels of government, and what can be improved there to wind up with a more accurate idea of what's actually going on in reality, because I haven't received very accurate answers to my questions about what's actually happening out in the field. There seems to be a lack of data sharing. How can this be cooperation be improved, collaboration, so that we make sure that the funds that are made available leads to efficiency and data sharing.
Je pense que
I think that there is certainly a level of collaboration with the provinces and territories. There are a number of committees at the ministerial and deputy ministers level, and we do work closely with our colleagues in the provinces and territories across a number of efforts, sharing best practices, sharing examples. For example, on the substance use programming, when we do have good examples of projects working in the provinces, yes, we certainly have forums that allow us to share optional approaches, best approaches. This is very good. Others can learn, of course, and we're all learning from each other how to improve our interventions to avoid overdosing. Of course, we can improve data sharing across all levels of government in order to be able to know what indicators will work well and share them. It's important to work together. You can't just be the federal government or the provincial or the community level government. You really have to be able to work together, a group partnership with Indigenous peoples as well, and with healthcare experts, ensuring evaluations and data collection as well throughout to ensure that we learn as we go, ongoing, as a program is used. Thank you.
We'll pose the final few questions for today's panel. The next 2.5 minutes. Mr. Johns.
Thank you, Mr. Chair. I'm just going to read a quick quote from just 2 weeks ago in the Vancouver Sun. And it states that in July 2020, the Canadian Association of Chiefs of Police expressed support for evidence-based medical treatment that included safe supply. Now, Victoria Police Staff Sergeant Connor King said that based on his experience, Dilaudid is not the drug most people want, and so the pills are indeed being sold illegally. But various prescription drugs have been sold on the streets for decades, said King, a court-certified expert witness on the trafficking of fentanyl, heroin, OxyContin, cocaine, and methamphetamine. He says that there has always been Dilaudid and OxyContin and other powerful opioids in the teen environment, high school, and university campuses, end quote. He states, in addition, when I look at the coroner data, we're not seeing a link between safer supply drugs and lethal overdoses. King called their version of safe supply a small piece of an enormous picture as illicit drugs flow into BC via organized crime. Fentanyl coming into the province is highly toxic and deadly, and methamphetamines manufactured in Mexico and shipped or smuggled across the U.S.-Canada border are plentiful, powerful, and cheap. He says there's never been greater availability of cheaper drugs that are more toxic than the situation we face now, he said, and none of that has anything to do with prescribed or safer supply drugs. And he goes on to later say that, I'm a fan of looking for alternative ways for people to access drugs that are going to keep them alive, but I leave that to the medical community to sort out, said King. Now, we've heard similar responses from the City of Vancouver and their police department, the Chief Coroner of BC. What are you hearing from police? Is there a consensus, or overall, are you hearing that the support is still there for moving forward with safer supply as a replacement to the unregulated toxic drugs?
As I mentioned earlier, there are diverse views. We know people who have expressed concerns. There are some who support as well.
Sure.
I think when we hear it, it is as part of a suite of services. It is a connection to health and social services. Someone who is reaching out for prescribed pharmaceutical alternatives, someone who's reaching out and connecting
I guess
to
just
it.
the reason I'm bringing it up is
Mr.
that these are
Johns, your
experts.
question-
They're on the
your-
front line.
Mr.
right?
Johns, you have to let her answer the question. Your question lasted about 2 minutes, and finish, and then we're gonna bid them good day. Go ahead, Ms. Sachs.
Experts, and there are experts in health services, in law enforcement, in criminal justice system. We need to listen to a range of experts. They all bring their own expertise. There are some that have brought and highlighted the risks and benefit. There are some concerns. We need to look into those as well. We need to look at what is working and where it is life-saving, and how do we adjust so that we can continue and improve the programs that we have. And I think that's exactly what we're doing. I think when we hear from Canadian Association of Chiefs of Police, it is really looking at these, whether it is in terms of decriminalization, whether it's pharmaceutical alternatives, it is really looking at it as a suite of services that they are proposing.
Thank you, Ms. Sachs. Colleagues, that concludes the first panel. We're going to suspend briefly for the second one. Before we do, on the opioid study, we have not yet set a deadline for witness lists. May I suggest that the witness lists be in by the time the House rises, or say Friday, the 15th of December at 4 o'clock? Is everyone okay to have all their witnesses in by then? Thank you. That'll allow the analysts time to prepare a work plan over the winter. To all of our witnesses, thank you so much for your patience and your professionalism. As always, we very much appreciate you being with us. This is the first step in a fairly long journey and study, and it has laid the foundation for all of us to be able to do our work, and we're grateful to you for what you do and for your assistance to us in connection with this study. With that, we're going to suspend while the next panel gets situated, so probably about 5 minutes. Order 108, Sub 2, and the motion adopted on November 8th, 2023, the committee is beginning its study of the government's advance purchase agreement for vaccines with Medicago. We'd like to welcome the officials who are with us today from the Department of Public Works and Government Services: Andrea Andrechuk, Director General; Joëlle Paquette, Directrice Générale, Secteur des Services de Soutien.
Director General, Procurement Support Services Sector.
From the Office of the Attorney General, Andrew Hayes, the Auditor General. We have accountants, not lawyers, with us. So Andrew Hayes, Deputy Auditor General, and Susan Gomez, Principal. Colleagues, we received notice actually during this meeting that the Auditor General herself wasn't able to be here. I don't have any explanation for you except that it was a development that was very recent. So we have two opening statements. First of all, to all of our witnesses who are here, thank you. We have two opening statements. The first from the Auditor General. I presume that will be you, Mr. Hayes. So you have the floor for the next 5 minutes. Welcome to the committee.
Monsieur le Président, je vous remercie de nous.
Thank you, Chair. Thank you for this opportunity to discuss our report on COVID-19 vaccines in the context of the committee's study of the government's advance purchase agreement for COVID-19 vaccines with Medicago. Our report was tabled in the House of Commons in December 2022. I would like to acknowledge that this hearing is taking place on the traditional unceded territory of the Algonquin Anishinaabe people. Joining me today are Susan Gomez, the principal who was responsible for the audit. This audit examined how the federal government procured, authorized, and distributed vaccines to the provinces and territories to immunize Canadians against COVID-19. For the purpose of this hearing, we will focus on the procurement aspect of our audit. Overall, we found that Public Services and Procurement Canada provided the Public Health Agency of Canada with good support to secure enough COVID-19 vaccine doses to vaccinate everyone in Canada. Between December 2020 and May 2022, the federal government paid for 169 million vaccine doses. More than 84 million of those doses made it into people's arms.
Services and Procurement Canada used its emergency contracting authority. This provided the department with flexibility on a number of fronts, including using a non-competitive approach to procure vaccines from companies recommended by the COVID-19 Vaccine Task Force. The department established advance purchase agreements with 7 companies that showed the potential to develop viable vaccines. We found that the department exercised due diligence on the 7 vaccine companies. For example, the department examined whether the companies had the financial capability to meet the contractual requirements and were eligible to do business with the federal government. The department reached an agreement with Medicago on the 13th of November 2020. The government's strategy was to secure agreements with several vaccine companies in case Health Canada authorized only one vaccine. While this approach meant that Canada could end up with a surplus if all 7 vaccines were eventually approved, it also increased the chances of securing enough doses to support the largest vaccination program in the country's history. Mr. Chair, we are happy to answer the committee's questions where possible. However, given the confidentiality of the agreements, we are unable to discuss details relating to contracting costs or fulfillment of any of the specific agreements. This concludes my opening remarks. Thank you.
Thank you very much, Mr. Hayes. Next, from the Department of Public Works and Government Services, Andrea Andrechuk, for the next 5 minutes. Welcome.
Merci, Monsieur le Président, et bonjour. Je suis heureuse de...
Thank you, Chair, and good day. I'm pleased to appear before the committee to discuss Public Services and Procurement Canada's work on the advance purchase agreement with Medicago for COVID-19 vaccines. I recognize that this hearing is taking place on the traditional unceded territory of the Algonquin Anishinaabe people. Here with me today is Joël Paquette, Director General of the Procurement Support Services sector. From the earliest days of the pandemic, the government aimed to obtain secure, safe, and effective vaccines as rapidly as possible. There were a number of uncertainties. We didn't even know whether safe and effective vaccines could be created. This uncertainty led to a high global demand, followed by strong work on all governments' parts to obtain vaccines. The government's expert group on vaccines felt that it was a good idea to come up with a mixed portfolio of potential vaccines as quickly as possible. On the council of this expert vaccine task force, agreements were reached with promising suppliers, including Medicago from Canada. The advance purchase agreement with Medicago was signed in November 2020 and included an agreement for 20 million doses to be delivered by the end of December 2021, with options for up to 56 million doses beyond that. The contract was approved by the then Minister of Public Services and Procurement and other ministers, and the contract was authorized before it was signed by the Minister of Public Services and Procurement of that time. Since Medicago did receive authorization for its vaccine in February in 2022 from the Public Health Agency of Canada, the contract was changed to allow for the delivery of doses at the end of 2022 in December. Given the overall management of the investment, Public Health Canada asked Public Services Procurement Canada to reduce or eliminate the delivery of some of Medicago's doses in order to readjust its stocks and to avoid wastage and the costs of the logistics. And Medicago was also facing production challenges and delivery date challenges. So discussions were undertaken with Medicago to resiliate of the contract. The parent company, Mitsubishi of Medicago, announced that it was going to discontinue activities in North America and not commercialize its drug Covifense.
A $150 million non-refundable advance payment was made to Medicago in accordance with the advance purchase agreement, that Medicago met all terms for the payment, that the contract was terminated by mutual consent, and Medicago was released of its obligations under the advance purchase agreement, and no doses of Covifense were delivered. This advance payment was agreed to in negotiations in order to fund at-risk production of the vaccine prior to Health Canada authorization. In the termination by mutual consent, the government had no contractual right to request a return of the payment. The government is committed to being as transparent as possible while respecting the confidentiality clauses in these vaccine purchase agreements. Significantly, this agreement with Medicago, along with the 6 others, was the subject of the Auditor General report in December 2022. And in April 2023, the government shared unredacted copies of the 7 advance purchase agreements with the Parliamentary Standing Committee on Public Accounts. Senior officials from Public Services and Procurement Canada appeared in 2 in-camera sessions with the committee. Mr. Chair, Public Services and Procurement Canada played a key role in supporting the Public Health Agency of Canada efforts to ensure delivery of COVID-19 vaccines as soon as we could acquire them, helping save Canadian lives. Thank you, and I'm happy to take your questions.
Thank you very much, and we'll now begin with rounds of questions, starting with the Conservatives for 6 minutes. Mr. Perkins.
Thank you, Mr. Chair. Thank you, witnesses. My questions will all be for Public Service Procurement Canada. So October 18th, 2020 is the first agreement that was signed with Medicago for $200 million. When both, presumably on the advice of Health Canada and all the organizations you signed that agreement, you were aware that the World Health Organization would not do business with any company that has ownership of it by a tobacco company?
Thank you for the question, Mr. Okay, Mr. Chair. We put a contract in place with Medicago for doses at a time that we needed
I don't
to.
need the explanation about what the situation was like. You knew that Medicago was 40% owned by Philip Morris, correct?
Yes, we did.
And you knew that the WHO would not do and interact with any company, regardless of the efficacy of a vaccine, that had anything to do with tobacco. Is that correct?
That I'm not sure if we are aware or not. It's not.
It's an international agreement signed by the Government of Canada from 2005. You're not aware of the international agreement at the WHO on relationship with tobacco companies?
When the advanced purchase agreement with Medicago, the intention of it was to procure vaccines for Canadians to respond to the pandemic. It was an emergency contract for the sole purpose
I understand
of
it was an
procuring.
emergency contract. In other words, you weren't aware of it. So you knew that it would have no ability, either you didn't know it and didn't do your due diligence, or you were aware that it would have no ability to have any kind of international purchase beyond this country. So the reason that's important is because when you signed for, according to the president of Medicago and Public Accounts Committee, $773 million worth of vaccines that were never produced, you knew that all of those doses would have to be consumed in Canada. They could not be exported. What's the purpose of signing a contract with a company and investing $200 million of taxpayer money for those dosage numbers, in addition to everything else the Auditor General outlined, 90 million or 180 million doses of various vaccines? It seems totally irresponsible that the government would do that knowing it wasn't possible to have those exported.
We put the contracts in place to obtain enough doses for all Canadians at the time. We did not know.
That's enough for like 5 or 6
doses.
Mr. Perkins, you took a minute to pose the question. You need to listen to her for at least a minute to try to answer it. Go ahead, Ms. Paquette.
We did not know at the time which vaccines would actually be authorized. There was no vaccine that existed at the time that we put these contracts in place. So we took a risk of putting contracts with various suppliers for enough vaccines for all Canadians.
So you spent $200 million, over $200 million was the commitment to develop a vaccine that was not MNRA, that was based on tobacco, owned by a tobacco company, not knowing that the WHO agreement that Canada had signed would prohibit it from being anywhere else in the world. Doesn't seem very responsible to me. And then you contracted for $773 million, according to Medicago, in doses. This is $1 billion scandal of taxpayer money for 0 doses received. You just admitted there were 0 doses received. Who owns the IP?
Medicago owns the IP.
Wow. Wow. That's just unbelievable. $200 million of taxpayer money to fund a company that's owned by the Japanese to develop a vaccine that I understand had over 70% efficacy. And it got developed knowing it couldn't be released. And on top of that, contracted for about, I don't know how many, $770 million buys at $20 a dose. That's probably about 10 doses a person in Canada. You contracted, and we're on the hook for $150 million for, they never produced a single vial of the vaccine. And you think that's good. And the Auditor General thought this was good efficacy too. It goes to whether or not they actually did in the Auditor General a value for money audit. I don't know how spending $773 million on a vaccine that could never be produced or exported is good value. So why would the department, what's the motivation for the department to sign such a horrible deal when we don't even own the IP, and now the Japanese own the IP on top of everything else? Is that correct? The Japanese own the IP?
Medicago owns the IP.
It's a Japanese-based company.
It is owned by Mitsubishi.
Do you know how much they paid for Medicago, the remaining 40% Philip Morris in December?
No.
Last year, almost a year ago?
Do not have the information. What I can confirm, as I mentioned in my opening remarks, is the amount paid by Canada to Medicago was $150 million, not $200 million.
No. That's $150 million for the breach of the contract or their inability to deliver the vaccines. We also paid almost $200 million of taxpayer money to actually develop the vaccine.
We have put a contract in place with Medicago for 20 million doses, and at the time, we paid the $150 million for at-risk manufacturing because the company did not have an authorized vaccine at the time. They would have had to start manufacturing the vaccine prior to the authorization.
Thank you, Mr. Perkins. Thank you, Ms. Paquette. Next, Mr. Johari, please, for 6 minutes, sorry.
Thank you. I was getting worried my time is getting cut off. Well, first of all, good morning and welcome to our committee. So by way of preamble, it was during a very, very difficult time, and our government chose to take a multi-pronged approach. We signed, as you highlighted, 7 advance purchase agreement. So that's the purchase part of really the vaccine, and it was both international and in case of Medicago was domestic. We invested a lot of money in R&D, both domestically as well as internationally, and we also realized that we really need to build the domestic capacity. So when we look at Medicago, this is a cross between the very well thought out strategy of purchasing, which is hedging bet, focusing on R&D both domestically as well as internationally, and then building domestic capacity. So was it a sound strategy? I would say yes. Did we execute it? I believe when we look at the $172 million that was spent, and did it generate the result? I would say yes, it did, because we managed to get a vaccine approved by Health Canada. Did we know about the fact that World Health Organization is not going to approve this vaccine because of its affiliation with a, let's say, cigarette manufacturing company? I don't know, and we are not 100% sure. And this might be an area that's worth, diving to a bit deeper. But even the issue of IP, we invest in a lot of, through our various programs, federal government through various programs, and invest in a lot of our companies. And the IP remains with the company. I just finished making an announcement on Friday for a company, Visual Defense, which the government of Canada, through Scale AI, invested about $1 million, and the IP belongs to the company. So I'm not sure whether that is who owns the IP should be the focus of this. I think what we need clarification, and this leads into the question that I'm about to ask you, is what the government of Canada paid $150 million, aside the 172, which we can justify. What did we pay the $150 million for, and what did we get as a result of it? Now, anyone can answer that question.
$150 million was an advance payment. It was intended to support at-risk manufacturing by Medicago, meaning Medicago had to proceed to conduct activities before they knew they would have Health Canada authorization. So that represented a risk for the company, and these payments were intended to fund those at-risk activities.
So can you expand what that at-risk activity means? Because in my mind, I'm looking at 172, and the 172 went into the R&D, setting up a facility, then hiring people, doing the R&D, growing, extracting, running clinics, et cetera, et cetera. What is the difference between that 172 and the 150?
So as officials from Public Services and Procurement Canada, we can't speak to the Strategic Innovation Fund amounts. Those questions I would recommend to refer to Innovation, Science and Economic Development Canada. For the advance purchase agreement, the $150 million advance payment was intended for at-risk manufacturing, meaning activities leading up to the commercial scale production of the doses that were intended to be done prior to Health Canada authorization. And that was to enable Medicago to get doses produced as quickly as possible so we can get them in the arms of Canadians. And remembering the context that at the time when we entered into this advance purchase agreement, there were no COVID vaccines approved anywhere in the world.
In my mind, if I go back and say, we kind of allocated $150 million to Medicago to start building the facility in the anticipation that $172 million is going to pay off, and we're going to have a vaccine, and we want to manufacture ASAP, that is the money that where it went. Am I right to understand this? Because the terminology of at risk, for a layperson like me, it's a bit difficult. So is this where we spend the money?
So due to confidentiality clauses in the agreement and related to negotiations, we can't go into details on where the money was intended to be spent and what it may have been spent on, but we can say it was for at-risk manufacturing.
Okay, so it was for at-risk manufacturing, and I got about 30 seconds left. Can you explain why confidentiality clauses would still apply even if the contract was unfulfilled?
Confidentiality clauses were included in all 7 advance purchase agreements, and they survive the termination of the contract, meaning that even when the contract ends, those clauses remain applicable to both the supplier, Medicago, and the Government of Canada. It's a two-way confidentiality clause.
Okay.
Thank you, Mr. Johari. Suite, Madame Vignola pour 6 minutes.
Ms. Vignola, 6 minutes. Thank you very much, Chair. Ms. Andrachuk, in your opening statement, you stated that Medicago had respected all the conditions of the advance purchase agreement signed with the Government of Canada. Could you tell us something about those conditions? No, I cannot. If this has to do with the confidentiality clauses, so unfortunately I can't answer. All right, so we won't discuss the conditions, but if they were fulfilled, I would like to know why the $150 million was placed in the loss of public funds attributable to an accident, an illegal behavior, or an offense. The anticipated payments is correctly entered in the financial statements of the government as a loss, and this loss was registered as such, given that the agreement between the government and Medicago was terminated without any dose being delivered. So you call this an accident? It's certainly not an offense or an illegal behavior. Yes, indeed, accident. Thank you. Ms. Andrachuk. Would you agree to say that the World Health Organization decided to refuse to allow the vaccine to go forward as an emergency vaccine because one of the minority shareholders was a cigarette company?
Related to the ownership of Medicago and not related to the vaccine itself. But again, our purpose for the advance purchase agreement was to procure vaccines. The purpose was not for donation.
Okay.
The purpose.
Donc, ça n'a rien à voir avec la
So nothing to do with whether it was a valid vaccine. It was just had to do with a shareholder. All right, thank you. Did they evaluate the vaccine itself, or did they look at the list of shareholders of the company?
Si le Canada était allé à l'encontre de...
If Canada kind of didn't respect the World Health Organization, what would the consequence have been? Health Canada did authorize the vaccine for use in Canada, so it was authorized in February of 2022. We had Health Canada's authorization. We no longer needed the World Health Organization's authorization. Nevertheless, was the vaccine distributed? No. we did not receive a delivery of Medicago vaccine doses due to the fact that the contract was terminated. Okay, so Canada, had the contract not been terminated, could have received and distributed the doses, but not outside Canada. That's what I understand? Medicago's headquarters was purchased by Aramis Biotechnology recently. My question is as follows. By buying out their headquarters and other facilities, is Aramis Biotechnology now the owner of the IP of Medicago? Inaudible. Thank you. So you have discussed this advance purchase agreement. We know that the Medicago one didn't work. Of the 6 others, did they all work? The other 6 agreements, did we receive vaccines in the other 6 cases? There is another contract that was also terminated, but the remaining 5 delivered. So which is the other that was terminated? Sanofi. And how much did that cost us? I don't have that information. I didn't prepare that for today. But could you provide us with that? Yes, I shall. Thank you very much. Mr. Hayes, you brought up the 169 million doses, and of the 569 million doses that were ordered, does that include those that were provided to COVAX, lent to COVAX, or borrowed from COVAX? Yes, that figure includes everything offered in Canada, to Canada. So did we give back the doses that we had borrowed from the COVAX program? I don't know. That's perhaps something you could put to the minister. This would be a question for public health. Those doses weren't used. What happened to the tens of thousands of doses that we did not use? At the time that we finished our audit, the figures in our report were up to date, but we don't have information since. We have no further details to specify what happened to all the doses. All right, so we bought the 169 million. We used 84,000 of them. We can take it. Some of them, of course, were died on the shelf. They were just out of date. And am I in the right line of thinking here? I think so. It's also likely that there was some wastage of doses. There are many reasons for which waste, occurs in this sort of dosing. But I think your thinking is correct. So when the doses are wasted, we nevertheless have paid for them. And in the public accounts, where does that appear? Where does that sort of loss appear, the wastage? I'll have to ask the other audit teams for that detail, but I could provide you with an answer. Thank you, Ms. Vignola.
Mr. Davies, please, for 6 minutes.
Thank you. To Public Works, on what date did the Government of Canada decide to release Medicago of its obligations?
Contract was terminated in June 2023.
Thank you. And can you explain why the Government of Canada decided or consented to terminate the contract and release Medicago of its obligations?
The contract was terminated by mutual consent, meaning that both parties were interested and agreeable to the termination. Medicago...
No, I'm asking why the Government of Canada did. I understand it's mutual. Yep. I want to hear why the Government of Canada did.
The Government of Canada, as part of its overall supply management, and seeking to reduce logistics costs and right-size inventories, was interested in either reducing or eliminating deliveries of Medicago doses. And this occurred at the same time that Medicago was experiencing some challenges in achieving commercial scale production. And
Was it because Medicago had been determined by the WHO that it would not be allowed to market its vaccines because of its connection to the tobacco industry? Did that figure into the Government of Canada's thinking?
The reason had to do with supply management, looking at the number of doses.
Okay. Now, the government initially refused to provide any details on this loss, stating that this information could not be divulged because of confidentiality agreements with the contractor. I think you've referred to that a few times today. Now, subclause 22.3H of the Government of Canada's contract with Medicago, which was disclosed to this committee in June of 2021, says the following, quote, Canada will be permitted to disclose confidential information of the contractor for the purposes of government administration and operation and in the exercise of Crown privileges. For greater clarity, this includes reporting to the Parliament of Canada, end quote. Can you outline why the Government of Canada did not believe that this provision would permit it to disclose the loss of $150 million to Parliament when it so explicitly says so?
We make all efforts to respect the confidentiality clauses in the contracts. The suppliers of all 7 advance purchase agreements have indicated how important this is for their business. And so I think whether that clause could allow us to release additional information or not would need to be further studied. But at
Isn't transparency and accountability to Parliament and the taxpayers who pay this money, is that not important?
So the Government of Canada has made all efforts to be transparent with these contracts. We provided fully unredacted copies of all 7 advance purchase agreements to the Parliamentary Standing Committee on Public Accounts. Furthermore, unredacted copies of the contracts were provided to the Auditor General and subject to a report. And officials...
Well, with respect, I know we forced the government to do that at Health Committee as well when they were fighting us tooth and nail to not provide those contracts. But I'll move on. In April 2022, Dr. Gaston Deserres, a medical epidemiologist at the Quebec National Institute of Public Health, noted that the problems Medicago would have in getting COVID-19 vaccine with close ties to the tobacco industry approved by the WHO were, in his words, quite obvious, quote, and that the federal government, quote, should have known this issue would arise before investing in it. He was quoted as saying, they wouldn't have to work hard to know that Philip Morris was also an important shareholder, end quote. Can you confirm if the Minister of Public Works and Government Services was aware of Medicago's ties to Big Tobacco prior to signing an advance purchase agreement with the company?
But the purchase agreement with Medicago was intended to purchase doses for Canadians in response to the pandemic. And World Health Organization approval was not required for that purchase and for us to get doses delivered for use for Canadians.
So in 2004, 20 years ago almost, Canada ratified the legally binding WHO Framework Convention on Tobacco Control. This treaty states that governments should not accept, support, or endorse partnerships with the tobacco industry or any entity or person working to further its interests. Given that Philip Morris International owned 21% of the Medicago shares when the Government of Canada signed its advance purchase agreement, can you explain why the government didn't believe that this entity was working to further the interests of the tobacco industry?
Early in the pandemic, there was intense global competition to secure vaccines. There were no approved vaccines worldwide. Countries were pursuing very aggressive procurement strategies to get doses as soon as possible. Because Canada didn't have a strong domestic capacity, we didn't have a strong footing to procure vaccines. And our goal, the goal of the government, was to procure vaccines as early as possible to get them in the arms of Canadians.
I respect that, and that makes a lot of sense. But the issue here is Canada was also signatory to a legally binding treaty that said it would not sign a contract with a company with significant ties to the tobacco industry. That's the nub of the question here, and that's why we lost $150 million, because ultimately the WHO would not permit the Medicago vaccine to be sold commercially. And that's why the taxpayers lost $150 million. What am I missing with that take on this?
The Government of Canada put a contract in place with Medicago to obtain vaccines for Canadians. Had we received Health Canada approval, well, they did receive Health Canada approval. Had we had the vaccine, we would have been able to vaccinate Canadians.
So why didn't we proceed in that respect then?
Thank you, Mr. Davies. That's your time. Monsieur Deltel est la prochaine pour...
Mr. Deltel is up next. You have 5 minutes. Thank you, Chair, and welcome to our witnesses. Chair, I'm a guy from Quebec. I was a journalist, and I know Medicago very well. I actually covered Medicago as a journalist, and I think this is a very troubling matter. We need to keep in mind that this story has been contaminated by a virus, not a medical virus, but a property virus. In 2005, Canada and 125 other countries around the world signed the OMS Framework Convention on Tobacco Control. And I quote, that this policy not be, or no policy, be influenced by the tobacco industry. So it's clear, as soon as the tobacco industry asks for funding, the World Health Organization says no. So in 2008, Philip Morris became a shareholder, 21%, of Medicago. In March 2020, in the middle of the pandemic, of course, we all were looking for solutions. The government on the 23rd of March announced that it would help companies carry out research. And I quote, funding will allow Medicago to quickly go forward to medical trials to then scale up production in response to the pandemic. Ladies, at that time, did you know that Medicago had, as a shareholder, a tobacco industry so would never be recognized by the World Health Organization? Public Health Agency Canada asked us, following the advice or based on the advice of scientists, to go ahead with a purchase or an advance purchase agreement with Medicago. My question is as follows. Did you know that Medicago had, as a shareholder, a tobacco company, and thus the World Health Organization would never, ever, ever recognize that work?
Partial ownership by PMI.
So why did you go on?
We could not presume what decisions the World Health Organization may or may
Madame,
not
comment vous ne
take.
pouvez pas présumer une entente signée par le Canada?
Well, I'm sorry, but how could you not presume an agreement signed by Canada with so many other countries that stated clearly, black on white, that if tobacco had anything to do with it, it would not be recognized? How could you imagine it would be any different, that agreement, 2005, that Canada had signed?
The COVID-19 pandemic was an unprecedented situation.
Oui, ça je sais, mais les textes sont clairs.
Yeah, I know, but legal texts are clear. Mr. Deltel, in this committee we have adopted a procedure to the effect that a witness has as much time to respond to the question as you have to put it. So please stop interrupting without at least leaving time for a response. That's why I'm asking yes or no. Did you know, yes or no? We knew that the company was in part owned by a tobacco company. But the vaccines were purchased for Canadians because we didn't know who would come out with reliable vaccination and vaccine for Canadians. So you knew, though, that the World Health Organization would not recognize the work of Medicago. We could not foresee what decision the World Health Organization would take. We didn't presume one way or the other, given that the pandemic was such an unusual situation. There was so much uncertainty.
In completely new circumstances, we couldn't presume what OMS would do.
Quand en octobre 2020,
when in October 2020, the federal government, $360 million, gave it to Medicago, did you advise the politicians of the situation at that time? That would be a question to put to innovation, science, and did you warn them of innovation, science, and so on, that there was this virus, the virus of the ownership of Medicago, such that the World Health Organization would never recognize it? We were not contributing to that decision-making at the time. We set up a contract with Medicago for vaccine doses for Canadians. We had no other vaccine available at that time. Okay, I've only got 20 seconds left. Given that Canada is a signatory of the World Health Organization framework on tobacco, has Canada actually breached its own agreements? I'm not able to answer that today here because Canada did sign the Framework Convention on Tobacco, and it's quite clear no one can fund any research for the tobacco company when the tobacco company is involved, and that's exactly the case of Medicago, and that's why the problem is as it is still today. Thank you, Mr. Deltao. And now, Ms. Sidhu.
Thank you, Chair. My question is to the Public Works. It's important to emphasize that the decision of halt the operation of the Medicago vaccine is not in any way related to the safety of the vaccine or other technical reasons. Multiple research reports state that the Medicago vaccine was effective in preventing COVID-19, caused by many variants with efficacy ranging from 69.5% against symptomatic infection to 78.8% against moderate to severe disease. According to the New England Journal of Medicine, the participants for these studies were from 85 centers across Argentina, Brazil, Canada, Mexico, UK, and the USA, pointing to the benefit of the vaccine for people worldwide. Can you talk to us about the trial process? Also about what information was made available to you about it?
You would have to direct that question to Public Health Agency of Canada. We were, the vaccine task force studied the vaccines or the potential vaccines. They provided advice, and then the Public Health Agency advised Public Services and Procurement Canada to proceed with advanced purchase agreement with those 7 vaccine suppliers. So our role is to purchase on behalf of another government entity what they require in order to deliver on their programs.
How was risk shared in this environment? How was the risk shared in this environment? Can you explain that?
What risk?
Advance purchase agreement, the agreement with Medicago was announced on October 23rd, 2020. Health Canada approved the Pfizer's COVID-19 vaccine on December 9th of that year. In fact, all the agreement entered into the negotiated at a time when none of these manufacturers had approved product yet. Can you tell us how that uncertainty affected PSP's work in negotiating these advance purchase agreements?
So we entered negotiations with all of these suppliers to obtain a share of their vaccines as soon as they would be available for Canada. And so you're in a position where you're globally, all of these same vaccine suppliers are also trying to obtain agreements with other countries. So the objective was for Canada to obtain agreements with them as soon as possible so that we would have a viable solution of a vaccine as soon as they obtained Health Canada approval as soon as possible. And we succeeded by, with Pfizer and Moderna in December, to have vaccines for Canadians. So it was a risk of possibly not having any vaccine with any of these suppliers, but it was a risk that we took, not knowing which one would obtain Health Canada approval and when.
Thank you. Can you tell us what exactly Medicago was contracted to do, and what were the milestones that this contract were measured against?
So the advanced purchase agreement with Medicago was awarded in November 2020, and there was a firm commitment for 20 million doses to be delivered by the end of December 2021, and as well as optional doses up to 56 million additional doses. The contract was later amended because the Health Canada authorization was received in February 2022, so the contract was amended to change the delivery of the 20 million firm doses to the end of 2022.
Mr. Chair, how much time have? Sorry? 30 seconds. I'll pass on.
Thank you, Ms. Sidou. Suite, Madame Vignola pour...
And now Ms. Vignola, 2.5 minutes. Thank you very much, Chair. Ms. Andrzejczyk and Ms. Paquette, are you aware of whether the government is currently negotiating with Mitsubishi Tanabe Pharma Corporation to obtain the IP for Medico's vaccine? We're not currently negotiating that. All I can say is that the contract is terminated. All right. So it seems that Aramis Biotechnology, we're not sure whether it bought the IP along with the parent company. From the point of view of PSPC, we are not in negotiation over this at present. All right. When it was publicly known that Philip Morris was a party to Medicago, Mr. Philip Morris actually sold his shares to Mitsubishi. And thereafter, Mitsubishi decided to technically put Medicago out of business. It's in bankruptcy. Now, if the government of Canada or any other third party had an agreement, would we now be facing this loss, or could the company have continued its activities and could it have grown?
What decisions Medicago may or may not have taken, that is not ours to speak to. I can speak to just the point of view of the Government of Canada was also conducting supply management activities, looking at all doses we've received through the 7 advanced purchase agreements. So for the part of the Government of Canada, that was a consideration on the side of Medicago. I understand Medicago may also be appearing before this committee, and perhaps it is a question that could be further asked to them.
Merci.
Thank you. Thank you, Ms. Vignola.
Questions for today will come from Vancouver, I believe. Mr. Davies for 2.5 minutes.
Thank you, Mr. Chair. No, I'm in Ottawa, but now picking up the thread, you stated that there are no negotiations currently going on between the government and Mitsubishi to obtain the IP produced by Medicago. Was there such negotiating going on? And if so, when did it end?
So just to clarify, I'm here today as an official of Public Services and Procurement Canada, and there are no negotiations currently being led by Public Services and Procurement Canada with respect to procurements. I cannot speak to the full government on that point.
The reason I ask is the Minister of Innovation, Science and Industry, François-Philippe Champagne, stated to the press on November 7th, so about a month ago, that the government was in the process of negotiating a settlement with Mitsubishi to obtain the intellectual property produced by Medicago. Do you have any knowledge of that?
You read or referred to Innovation, Science and Economic Development Canada.
Okay. In November 2023, just a month ago, former Parliamentary Budget Officer Kevin Page was quoted in the National Post saying, quote, "It seems wrong that the Public Health Agency of Canada refuses to answer your questions about how money has been spent and written off," end quote. Similarly, current Parliamentary Budget Officer Yves Giroux commented that the government's initial refusal to disclose details about the $150 million loss due to the unfulfilled contract with the vendor was, quote, "highly unusual," end quote. Do you agree with that assessment?
So the Government of Canada is very careful to respect confidentiality agreements included in the contracts, and the government has provided fully unredacted copies to the Standing Committee on Public Accounts as well as to the Auditor General to be inspected, and officials from Public Services and Procurement Canada appeared.
Well, if that's the case, you interchangeably say you can't do it because of confidentiality, but then you contradict yourself by saying, well, we gave the full unredacted contracts, and you're here today talking about the contract.
Those were all provided with appropriate confidentiality agreements in place with those who were reviewing those agreements. So the information they received was maintained confidential. There was also a redacted copy of the 7 advanced purchase agreements provided to this committee earlier.
Finally, given the grave impact of tobacco on public health and the well-documented history malfeasance from the tobacco industry. Can you explain why the government of Canada didn't take a strong position by refusing to enter into a contract with a company that had such strong ties to an international tobacco producer that is linked to a known carcinogen?
The priority, the main goal of the Government of Canada was to secure safe and effective vaccines for Canadians as early as possible. And the procurement strategy taken was all with that goal in mind. And that is why there was a diverse portfolio of 7 different vaccines pursued in order to get best chances. Given there was a lot of risk at the time, we didn't know which vaccines, if any, would get Health Canada approval, and even if they did, when they would be available.
Thank you, Mr. Davies, and
Thank
thank you to all of our witnesses. That concludes the round of questions. Colleagues, reminder that we're meeting on Wednesday evening from 6:30 to 9:30. 1 hour on this study and 2 hours on women's health. To all of our witnesses today, thank you so much for your service to Canadians. Thank you so much for being available to come to committee and to answer the questions so patiently. This is our first hour on this topic, and there will be several others, so it's once again a good foundation for us to work from. We really appreciate you being here. Is it the will of the committee to adjourn the meeting? Not all at once. We're adjourned.